Politicians of Indian origin. Thank you all for joining us today this morning. I'm Dr. Vemuri Murthy, Program Director of the CME program. We have an informative 2.5-hour program from experts in the field of hepatology. This workshop is accredited by the Chicago Medical Society for AMA Category 1 2.5-hour CME credits. We have 3 distinguished speakers. Each speaker has about 35 to 40 minutes of presentation, followed by the question and answer session for 30 minutes. Please post your questions on the chat line. Now, this year's CME webinars are designed with output from the AAPI membership for the topic selected. I thank my committee members, Dr. Naveen Nanda, Dr. Rohit Vasa, Dr. Ravi Kumar, Dr. Kalpalata Guntupalli, and advisor, Dr. Ranga Reddy, for their help. Needless to say, this year's CME webinar is the vision of the AAPI president, Dr. Sudhakar Jonalgadda. Thank you, Dr. Jonalgadda. I thank the chairwoman of the AAPI Board of Trustees, Dr. Sajani Shah, for her support. So she'll be honoring our distinguished guests at the end of the workshop. I also thank the AAPI Executive Director, Ms. Vijaya Kodale, for all the technical support she has been providing. Finally, our committee thanks the enormous support of these programs from AAPI membership, members of the Chicago Medical Society, and our distinguished Indian guests. At the beginning, it's my pleasure to introduce the AAPI President, Dr. Jonalgadda, as the moderator of the workshop. He's a board-certified gastroenterologist and transplant hepatologist trained at the University of Miami, Pittsburgh, Georgia, and Hamburg in Germany. He is a former clinical assistant professor at the Medical College of Georgia. He is currently practicing at Coffee Regional Medical Center in Douglas, Georgia. He received recently the prestigious Pravasi Bharatiya Samman Award from the President of India. Congratulations. Dr. Jonalgadda, you're on.
Thank you, Dr. Murthy, for a kind introduction. Indeed, thank you again for your help for this year's CM webinars. Outstanding, outstanding. Thank you again. Good morning to everyone, to members, and welcome to our the first hepatology mini symposium. We got to the top-notch hepatologists in the world. I say they're here today to speak for us, and it's a real treat for us and accepting our invitation, Dr. Naga Chalasani, Dr. Rajan Reddy, Dr. Varman. And this is a lot of work, and really the CME committee, webinar committee, doing an excellent job, taking the time and giving all these webinars this year. And I'm happy we could be able to deliver. And again, welcome to today's mini liver symposium, Dr. Murthy.
Thank you, Dr. Jonalgadda. Now it is my pleasure to introduce our first distinguished speaker, Dr. Naga Chalasani. Dr. Chalasani is David W. Crabb Professor and Interim Chair of the Department of Medicine at Indiana University School of Medicine. He has published over 350 full-length papers and is the lead author for the Multi-Society Practice Guidelines on the Diagnosis and Management of Non-Alcoholic Fatty Liver Disease. He has been continuously funded by the NIH since 1999 and is currently the principal investigator for 4 NIH grants. Dr. Chalasani.
Can you hear me okay?
Yeah.
Yes.
Thank you so much for a kind introduction and kind invitation. And also, Dr. Jonalgadda, such a pleasure to be here. I want to congratulate the AAPI for really wonderful CME programs that you all put together. During quarantine, I've not been able to join very many, but I just followed some of the speakers and really high class. And also want to say hello to many friends and some past friends and college mates. So it's really an honor to be here. I'm going to share my slides. Let's see how that goes. Can you see my slides?
Not, yes.
We just started, I think, there is no first slide yet, but we saw the frame.
Let me see. What about now?
Yeah, I
Yes.
can see, yes.
My video cam. So here is my my title. And once again, thanks for the invitation. Just please take a moment to look at my disclosures. I have research support. This actually goes to my institution. I serve on the DSMBs and also as a consultant to some of the companies that are in the NASH space. So this is my outline of my talk. We will first spend about 25 to 30 minutes on NAFLD and NASH. We'll go over background, definitions, risk factors, and so forth. And then last 10 minutes or so, we'll spend time on alcohol-associated liver disease. You know, NAFLD is really important in this country, worldwide, more so for this particular population, the audience here. I suspect nearly third to half of those who are in audience today and our relatives have non-alcoholic fatty liver disease. In a small proportion, some of us will get into trouble with this. We think it may be present in as many as a third of US adults, and then up to 15% of US children. It's just a matter of how hard you look. If you look using something sophisticated like an MRI, I think a third, 35% would have non-alcoholic fatty liver disease. But if you just use AST and ALT aminotransferases, you're just not going to pick up. And I think you lose about 3/4 of NAFLD. I'll come back to this again. Liver tests can be quite normal in non-alcoholic fatty liver disease, even when the disease is aggressive. Indians living in India, Indians living in the Western world, especially in the US, are at heightened risk for non-alcoholic fatty liver disease. Not a surprise, because this condition sort of tracks diabetes and also truncal obesity. It is the most common cause for liver transplantation and liver cancer in the US today. Really important slide though. Non-alcoholic fatty liver disease is sort of an encompassing term. It has two sort of broad phenotypes. One is simple fatty liver, also we just call it NAFL, non-alcoholic fatty liver. The other phenotype, important phenotype, is NASH, which you probably have heard numerous times. So first, the definition. NAFLD simply is the presence of hepatic steatosis in the absence of significant alcohol consumption or other chronic liver diseases. And we could spend a lot of time discussing about what is significant alcohol consumption. In general, for our purposes, more than 2 drinks on average each day in men, more than 1 drink on average in women per day, I think is sort of significant alcohol consumption. Simple fatty liver, basically less than 5% of hepatocytes should have fat, whether you look by histology or by imaging. But if you have more than that, you just call it fatty liver. If you just have fat in the liver, it is thought to be, from a liver standpoint, pretty benign. The risk of cirrhosis in somebody with just a simple fatty liver is quite minimal, 1 to 2% over the course of 30 years or so. They often die from other causes such as cardiovascular mortality. Whereas the NASH, though, is the bad guy. This is a histologically advanced fatty liver. It is characterized by steatosis, that's the fat, and also there is some other bad features. For example, the one that matters the most is balloon hepatocytes, meaning just the hepatocytes are dying. Pathologists can tell you, and also this can lead to fibrosis. And this is the NASH that gets individuals into cirrhosis and liver cancer. Within NASH, there are subphenotypes. The particularly progressive phenotype is NASH with stage 2 to stage 4 fibrosis. Mind you, stage 4 fibrosis is simply cirrhosis. Missed a slide. Clinical risk factors for NAFLD, I think many of you know. One thing, the majority of subspecialists see patients with non-alcoholic fatty liver disease, GYN, PCOS. You know, you have patients with rheumatoid arthritis and psoriatic arthritis have non-alcoholic fatty liver disease, and endocrinologists, of course, gastroenterologists, cardiologists see a fair number of NAFLD. This disease transcends our specialties. But the major comorbidities, not surprisingly, type 2 diabetes, hypertension, dyslipidemia, and the metabolic syndrome. If somebody has a lot of components of the metabolic syndrome and they're 40 to 45 years old, if you do an MRI, you're going to have more than 80% with non-alcoholic fatty liver disease. There are a number of emerging associations. Some of them are interesting because they become treatment targets, especially hypothyroidism, something we picked up very early on, and so on and so forth, listed here. And polycystic ovary syndrome is particularly of interest because of the age group, and also you can have advanced fibrosis by late 40. What I've not listed here, I'm not discussing, is the genetic component of NAFLD is really very interesting. There are a couple genes that you may want to hear about. One is called PNPLA3. It is a lipid hydrolase, and it almost behaves like a pseudo-Mendelian, meaning one gene defect can have profound effect. And the other is called HSD17B13, which is actually a good guy. If you happen to have the mutant HSD17B, your risk of liver disease is lower. And there's a lot of similarities in the genetic risk between alcoholic and non-alcoholic fatty liver disease. So the major causes of morbidity and mortality in NAFLD subphenotypes shown here in the columns are the subphenotypes for clinical purposes as well as clinical trials purposes. NAFL, we touched here, there is just simple fatty liver. Cardiovascular disease is the most common cause of death. Same thing with NASH with trivial fibrosis, stage 0 or stage 1 fibrosis. And stage 2 on higher fibrosis and NASH cirrhosis, this is where liver disease is the cause of death. Even in those entities, cardiovascular disease is the second most common cause. There is really, if one thing you want to take home today from this talk is cardiovascular disease is by far the most dominant cause of death in patients with NAFLD. It's sort of very interesting that we all get stuck on ALT 65, 70, but the LDL can be 150, and that's not been thoroughly addressed. And another point I'd like to make, though, if you take 100 people with NAFLD, 80% would have NAFL, the far left column. About 15% would have the second column, which is NASH with a little bit of fibrosis. It's only 5% of NAFLD would have the stage 2 or higher fibrosis, where there is increased risk of liver-related mortality and risk of liver cancer. How do you work up a patient with NAFLD? First and foremost, if you're seeing somebody who happened to come to you just because they have high ALT or AST, you must get imaging, because there is always the possibility of a space-occupying lesion, which you do not want to miss. Meticulous history of alcohol and medications. Keep in mind things like tamoxifen, amiodarone can cause fatty liver. So that can help in terms of your workup and your differential diagnosis. Meticulous alcohol consumption. What seemed like a straightforward NAFLD, for years later, patients have admitted to me that they're being sort of heavy drinkers. So first few times, you just have to keep asking in your clinic visits. And a couple other things I'd like to point out in this slide. Autoantibodies, ANA, anti-smooth muscle antibody, increased ferritin are common in this disease. There are epiphenomena. And when we see patients with NAFLD, we always get fasting lipid profile. As I said, dyslipidemia is quite common. The classic profile you see is increased triglyceride, low HDL, and a non-LDL cholesterol is quite high as well. They are important. When you look at subfractionate lipoproteins, there's a really atherogenic signature in these patients, and most patients with NAFLD are insulin resistant. Absolutely, either they're diabetic or they're hyperinsulinemic. As I said, 2/3 to 3/4 of patients with NAFLD will have normal liver enzymes, yet their degree, their severity of liver disease, their risk for progression is similar as if they had high liver enzymes. And liver biopsy is the one that we do to establish whether somebody has NASH and advanced fibrosis. Few things, obviously, you can do a liver biopsy in 1/3 of US population, so there's a lot of interest in non-invasive tests. And a couple of things for you to know. One is called FIB-4. This is just a bedside, like a Framingham heart score. I'll come back to that. And there are a couple of blood-based tests, CK18 and alpha. A lot is written about them. Neither one is approved. If something is going to make it to the market, this ELF by Siemens will make it to the market, but currently it's on clinical hold by the FDA. And imaging-based transient elastography, I suspect some of you have this FibroScan in your offices. I'll touch on that momentarily. A lot of excitement about MRI, but it is just expensive and not easily accessible. And especially in resource-poor settings, it's difficult to get on your patients. FIB-4, just really interesting. This is a score developed by Rich Sterling from VCU, widely used. Basically, this is a couple things. You all are great clinicians. For example, what happens when there is advanced fibrosis, AST to ALT ratio reverses. Normally in all liver diseases, ALT is higher than AST, whereas in advanced fibrosis, the ratio reverses. If you're seeing a patient, just eyeball the CBC and the CMP, the profile, liver profile, you can pick up when somebody has liver disease that's going to get him into trouble. If their AST is higher than ALT, that's a problem. The other one is low platelet count. That's all you need to look at. And if they are good, generally patients do very well. And this particular score is based on that principle of AST-ALT ratio and low platelet count. There are about 6 versions of FIB-4, basically including something we have done as well. But fundamentally, they all use the same principle. You add, for example, diabetes, so on and so forth. This is as good as all other bedside non-invasive markers. FibroScan, I would think, in the field of hepatology, I'm sure Dr. Sudhakar would agree, really transformed, at least in like what we can do bedside to patients, and then also our ability to not having to do liver biopsies. So this is a bedside. Our technicians can do this. This costs in the US about $100,000. And it gives a couple readouts. This is sort of transient elastography. There is a probe, and you put it on your rib cage and you sort of shoot it 10 times, and it just gives a readout right then. There are a couple of things. One is called CAP score, which is an indicator of liver fat. The other one is LSM, liver stiffness measurements. And really the important in FibroScan is liver stiffness measurement. If somebody has a good test, and that means the variability between 10 measurements is not very high, under 30%. And if the value is in double digits, normally it's 5 or 6. If any of your patients or your relatives bring you a FibroScan report, and if that shows double digits, 9 to 10 liver stiffness, we are talking about significant liver fibrosis. They are the ones you should worry about, okay? So moving on to principles of management, couple things. The first thing, the lifestyle modification and management of comorbidities is really critical, regardless what type, what subphenotype of NAFLD one may have. And this is NAFLD to NASH cirrhosis. And I think we hepatologists sometimes forget how important this is, but just a reminder that this is, I think, is what's going to save lives at a larger NAFLD level. And who benefits from liver-directed pharmacotherapy? There's 2 subphenotypes that I touched on, NAFLD with stage 2 or stage 3 fibrosis and NASH cirrhosis. And when we started clinical trials, I'll share with you some of the things that we have done. we started with NASH, but we realized I think there are sub-phenotypes that are targets for clinical trials and for you to give a liver-related medication. This is a cartoon that I borrowed from Mike Charlton from University of Chicago, just to tell you the clinical trials landscape is amazing. And I suspect some of you are active stock traders, and you know some of the NASH company stocks have gone tremendously high, but they also have bottomed out. This is constantly changing. Today in 2021, there is not an approved medication in the US. There is an approved medication in India called saroglitazar, which actually is the program that we are heavily involved in. And the data still, for it to be approved in the US, we just need many more studies. I'm talking about saroglitazar there. A lot of activity, some of you know, gastroenterologists. Here, when you give a drug for a patient with NASH, histological goals or resolution of NASH. Basically, you take a patient with NASH, you give a medication, and their NASH resolves. That's a success. And also, if somebody has advanced fibrosis, improvement in fibrosis is also an histological goal. Things that we think certainly work, there is abundance of data, is pioglitazone. I know the TZDs have fallen out of favor, but pioglitazone, the data are robust. It still is in the practice guidelines, and a careful discussion with your patients must occur, but I occasionally use, especially if the patient is glucose intolerant, early diabetic. The one that I'm a big fan of is vitamin E. I have a couple slides to share with you. Semaglutide is a new kid on the block. You know, this is remarkable, I think. A recent study, 72-week study that I'll share a slide with, had about a 12% body weight loss in the course of 72 weeks. That's phenomenal. Certainly don't work, or sodiaxycholic acid, metformin is great for insulin resistance, but if your goal is to treat NASH, it is not going to work, okay? Selonsertib and simtuzumab are two programs by Gilead were discontinued. Elafibranor is the GenFit program, had to be discontinued. Very recently, Allergan and AbbVie had the Senicriviroc program that had been discontinued as well. A lot of heartaches for those of us in the NASH clinical trials landscape. The row second from bottom, obeticholic acid, I'll show a couple slides, still in development, a lot of excitement. This is an FXR agonist. The next is resmetirom. This is a thyroid receptor, liver-specific thyroid receptor agonist. Seems like very effective. And I don't have much material on it, just watch out. And I think there are a couple second-generation thyroid receptor hormone agonists that are also coming along. This may well become part of armamentarium of NASH therapeutics. Saroglitazar is an Indian molecule. This is by Zydus. This is something I've been heavily involved in. I was told this is the first new chemical entity ever developed by India, because the Indian companies are very successful in generic market, but we have not developed our own molecule, and the saroglitazar is a exemplification of what's developed in India by itself. Weight loss, this is really important. You know, this is a disease of abundance, eating more, eating a lot of carbohydrates, not enough protein. So lifestyle modification is critical, but what's the milestone one must achieve is a 10% or higher body weight loss. And if one is lucky to achieve this weight loss, there is 85% NASH resolution and a 45% fibrosis improvement. Unfortunately, this is achieved only in 10% of patients. The slide here describes a study published from Cuba, Dr. Eduardo Villar Gomez, highly cited from 2015. We've been fortunate to recruit him to IU and a really prolific researcher. What about bariatric surgery? It can be effective in selected patients. This is the statements from the practice guidance. As Dr. Vemuri had said, I had the pleasure of leading was published in 2012 and subsequently in 2018. What basically, let me summarize. What it says is in carefully selected patients with foregut bariatric surgery. When I say selected patients, they must not have portal hypertension. They must not have decompensated liver disease. And it must be at a center that knows how to do bariatric surgery, and your surgeon should be experienced. And if these things happen, and if the patients undergo and if they recover, they can do quite well, just not from a NASH cirrhosis standpoint, but from other comorbidities. Most of you know that bariatric surgery improves survival in patients with significant obesity. But though there is an increased risk of morbidity and mortality with bariatric surgery in NASH cirrhotics, I think it goes from 0.6 to 1.8%. General population, significant risks are about 0.6%. It goes up to 1.8%. So I think good risk-benefit discussion, I think, can be quite helpful. Piven's trial, this was done now 10 years ago. Arun Sanyal was the lead author. I was heavily involved in this study. This is in patients with NASH, compared pioglitazone and vitamin E versus placebo. Interesting story, when we took vitamin E, this was given at 800 international units. We thought this would be a second placebo. Turned out it was actually more effective than pioglitazone. Numbers needed to treat was about 6, if I remember correctly. And actually numbers needed to treat for vitamin E was only 4 for NASH resolution. For pioglitazone was 6.6. And this is a more recent study, once again done from IU. You see the first author is Eduardo Villar Gomez. This is summarizing our own experience. This was published in Hepatology, one of our lead journals, showing vitamin E given at 800 international units per day in the NASH cirrhotics improved survival. This is I think only one of 2 studies, both from us, showing any compound improving survival. And this was quite statistically significant. And also, I think time to decompensation is also improved. So in my patients with NASH cirrhosis, I prescribe vitamin E just to all of them. And one thing, though, I discuss about risk, there is a very, very slight risk of increased risk of prostate cancer. If you talk to people who are vitamin E aficionados, they don't think it's true. But nonetheless, I do mention that risk when I prescribe vitamin E to my patients. Obeticholic acid, I would say, last 7 to 10 years, there's been a lot of excitement about obeticholic acid. This is an FXR agonist. If I'm not mistaken, this may be approved in India as well. This is made by Intercept. I'm not, so let me just go over the data. This is a paper that we published in Lancet, I think 4 or 5 years ago, showing obeticholic acid given at 25 milligrams per day. Obeticholic acid is this novel nuclear receptor FXR agonist. It basically it intercepts the liver-gut axis through bile acids, FGF19-21, and sort of bile acid synthesis. Turned out to be FXR is a very important pathway. And this was very exciting. When the results came, Intercept stock went from something like $40 to $500. This paper from us generated many, many millionaires. And this was followed with a subsequent paper. Zubair Younasi was the first author in Lancet. Once again, I think this was published just late 2019. Depending on how you look at it, this either is a success or a failure. Upper left panel here showing improvement in fibrosis. This is, I think, was a 72-week study, 23% compared to 12% in placebo, highly significant. And whereas if you look at NASH resolution, it was not. To me, this was not a great success because the hype that was built around this particular program, we thought, if you give this compound, which was priced quite high, heavily, if only 23% respond, and there are the liabilities, this compound has liabilities. One is significant itching. The other is increase in LDL, some concern for increased cardiovascular risk as well as risk of drug-induced hepatotoxicity. FDA declined accelerated approval. Let me make it clear to you, this program is still ongoing, but nonetheless, there are liabilities. We just have to see eventually how this is going to play out. There are a number of second and third generation FXR agonists. I think their efficacy isn't any better than what we are seeing with obeticholic acid, and they also have the same liabilities. So I feel like FXR agonists will not be mainstay. They may be add-ons in smaller doses. We just have to see how that will play out. This particular paper by Professor Phil Newsome from UK and multiple authors from the United States published this New England Journal paper in November. Highly effective. You know, this 0.4 milligrams sub-Q semaglutide, which is currently in the market for diabetes management, resolves NASH in up to 50% of patients in 72 weeks, and also 12% body weight loss. And this was associated with improvement in glycemic control and good favorable lipid profile. And they are now in a phase 3. I want to point out, though, is that there was not improvement in fibrosis. Let me back it off. Because of high placebo response, this trial did not see an improvement, a statistically significant difference in fibrosis improvement. Nonetheless, people in the field are very excited about GLP-1 agonists. And if you're wondering if we can ever see oral semaglutide, my understanding is the company has discontinued because of inconsistent bioavailability. Just sort of one of the last slides on NAFLD part of my talk. As I said, NAFLD cardiovascular disease is such a big kahuna in this population. Statins must be used in this population. There's a lot of concern about hepatotoxicity, but let me tell you, the risk of serious hepatotoxicity is quite minimal. Work we and others have done over the course of the last 15 years have consistently shown. Late Hy Zimmerman is a pioneer of hepatotoxicity, said statins bark, but they don't bite, which is true. Many patients, we put them on statins, their ALT may go up. If their bilirubin is normal, if their ALT and AST is under 200, just treat through those elevations, and often, most times, the patients will settle down. More important from statins is the muscle aches and myopathy rather than liver toxicity. And as I said, they have a lot of hypertriglyceridemia. I start with omega-3. There are other compounds. You can use fibrates, but I think there is risk of hepatotoxicity with fibrates, especially in NAFLD patients. So take-home messages, Asians, especially Indians, are a highly susceptible group. Steatosis is hepatically benign, but NASH can be progressive, can lead to cirrhosis. As I touched on multiple times, there is just a clustering of cardiovascular disease as well as type 2 diabetes in this population. Really, the key is to just not get focused on liver disease in this patient population, just pay attention to diabetes control, just the smoking, lipid management, that I think that's where that's going to save lives of your patients. And what's looking exciting to me are semaglutide and resmetirom, which is the thyroid receptor agonist, are the things that you should watch out in terms of what might get into guidelines in next iteration. Moving on, sort of last 5 to 10 minutes, let me touch on alcohol-associated liver disease. The experts in the field don't want us to call this alcoholic liver disease anymore, because it's almost, when you tell a patient alcoholic liver disease, you may be telling a patient they're alcoholic. Often they are, but I think this is a bit semantics, but this is sort of the recommendation from the societies. Numbers of alcohol use are very sobering. Excessive alcohol use increasing worldwide. If you followed, for example, the risk of alcoholic cirrhosis in the UK under the age of 30 has risen by 400% in the last 15 years. Under the age of 30, we are seeing the same numbers here. Prevalence of binge drinking in adults in the past month is about 26%. Adult men, alcohol use disorder is 5.6%. Alcohol consumption in the US has increased by about 14% in early COVID-19 pandemic. And then I suspect it's much higher. And 48% of all cirrhosis deaths are alcohol related. Unfortunately, the highest risk age group is the peak productive years, 25 to 35. And this is what we've seen in the AIDS epidemic and back in the 80s and 90s. And from 1999 to 2016, annual deaths from cirrhosis have increased by 65%, primarily driven by alcohol in this sort of a peak productive age group, 25 to 35. Some other things that women are higher risk than men for alcoholic liver disease. They only have to consume half the amount, but their risk is double, and the duration to get into trouble is about half. So keep that in mind. There are many theories why that is the case. And then wine is better than other forms of alcohol. And finally, daily drinking is worse than periodic drinking. If you're going to drink 2 drinks over the course of a week, or if you're going to drink 7 drinks, drink them or 2 sittings as opposed to drinking every day. Let me just walk you through this. I'm not sure how well this is coming. Everybody that drinks about 6 drinks per day for 6 weeks will get alcoholic fatty liver disease. But if you stop drinking, it'll go back, normalize. In a small proportion with alcoholic fatty liver disease, small proportion, some of the risk factors that I've told you, but also there's a strong genetic underpinning, can get into this alcoholic steatohepatitis or cirrhosis. That is the group that we worry about. I have slides to share with you. And it's not news to you that once you have alcoholic cirrhosis, especially those who are continuing to drink, can get into decompensated cirrhosis and can develop hepatocellular carcinoma. Alcoholic hepatitis, this is the one we all dread. This is sort of a florid presentation of heavy drinking. We all have studied in our textbooks that patients are emaciated, which we don't see anymore. Even the alcoholic hepatitis patients are heavy built because we have now patients who are drinking heavily also eating a lot. And its frequency is increasing. Unfortunately, as I said multiple times, these individuals are often in their 30s and 40s. And it's unfortunate you're seeing young moms, they're 30s, they've been highly productive socially and employment-wise with young children, just coming to die on the wards. It's really frightening. And anorexia, fever, leukocytosis, rapid onset of jaundice, once again, AST to ALT ratio is more than 1.5. And just a rule of thumb in alcoholic liver disease, AST and ALT just don't go above 300. If you see that in somebody drinking heavily, there's something else going on. Maybe they're taking Tylenol or something else. When somebody presents with advanced alcoholic hepatitis, they by then already have cirrhosis, high fatality rate. Couple of things, markers that we depend on when we see patients with alcoholic hepatitis. One is called the Madry's discriminant function. This is Dr. Willis Madry, a giant in the field based on total bilirubin and prothrombin time. And MELD, this is a metric that we use for liver transplant placement, a list placement based on bilirubin, INR, and creatinine. And these are the things how we risk stratify patients. Things to watch out in patients with alcoholic hepatitis is severe malnutrition, muscle wasting, sepsis, acute kidney injury, and multi-organ failure. And really, these are the things you have to watch out if you're consulting on a patient or if you're taking care of a patient. Be highly suspicious for infection, even with a slight bump in white count, especially they already have leukocytosis. You may have to preemptively start a broad spectrum antimicrobials. And you have to manage their volume status very carefully. If you over-diurese, they get into acute kidney injury, and then it's just a nightmare. Oftentimes, they just don't make it. Just the algorithm, you have to confirm the diagnosis, as I touched on, evaluate the nutritional status, and start very early on, look at the substance abuse and social structure evaluation and rehabilitation. And only selected patients with meeting certain criteria can receive prednisone. Unfortunately, in the last 35 years, there have been no new developments, therapeutic developments for acute alcoholic hepatitis. Prednisolone that was developed in 1960s and 70s remains sort of the only therapeutic option available, but this is only select patients eligible. I would suspect under 25% are eligible for prednisone. A small fraction of them responded to it. There are some data about N-acetylcysteine, but it's intravenous. I think you can give for 5 to 7 days while the patients are in the hospital. I cannot emphasize enough about the nutrition. There are many experts believe in enteral nutrition, at least 20 calories per kg body weight, and watch for infection, kidney injury. One thing is, once patients leave hospital, what's going to keep them alive is abstinence. What repeatedly we have seen, we get them out of the hospital and we have not paid enough attention to their rehabilitation. They go back to drinking. 6 months later, come and they just simply die. And just the construct of medical care in the US isn't really, isn't set up. Just last 2 or 3 slides, Dr. Wayne-Murray. And watch out for kidney injury. A thing that's developed in last 2 to 3 months, last 2 to 3 years is viability of liver transplantation for highly selected patients. Can be done. Our center, a few others are offering liver transplantation for select patients with ALCAP. Really last slide, management of alcoholic cirrhosis. There are no pharmacotherapy. Colchicine was tested in a large year cooperative trial. This was negative. Abstinence is once again critically important. There's a SAMI clinical trial that is getting done in the US. IU is leading that. Significant muscle wasting and poor nutritional status once again defines this condition. Pay attention to that. Liver transplantation can be effective, especially those who are sober, and there's a strong psychosocial support. So take-home messages, unfortunately expect increasing frequency of alcoholic hepatitis, alcoholic cirrhosis, and alcohol-related fatalities. And abstinence is really critical. Selected patients can benefit from liver transplantation, both for alcoholic hepatitis as well as alcoholic cirrhosis. And I really want to thank you for the invitation and for your attention. I think we'll take the questions and answers later on, right?
Yeah.
Yes.
Thank you, John. Thank you, Dr. Chelsea. It is a very highly informative update. We appreciate your sharing your evidence-based knowledge with us today. Thanks again. I'm sure, you'll have an opportunity of interacting with our participants, for some of the questions at the end of the 3 presentations.
Thank you.
Thank you. Moving on, our next distinguished speaker is Dr. K. Rajendra Reddy. Dr. Reddy, welcome. I don't see him here. Dr. Reddy, are you here?
Let me call him. I don't know what happened.
Yeah, that's okay. That's okay. Otherwise, we will move ahead with the third speaker.
Yeah.
Yeah, we'll wait for about a minute. Thank you. And well, this is Dr. Chalsani. This is a profound talk. This is what the difference it makes. When you listen from people like you who have been committed to this kind of the research and evidence-based information for several decades. And I'm sure we'll have a lot of questions. Welcome,
Dr. Reddy in the line.
Yeah, welcome, Dr. Rajendra Reddy.
Okay, thanks. Okay.
Yeah, well, thanks for joining. I know you have a pretty hectic schedule today.
Yeah. I'm on service, unfortunately.
Okay, thank you.
Well, you, Raj, stop taking call and service.
Yeah, that's
for too long.
Maybe you can write a letter for me. I need someone to help me out there. Yep, there you go.
Yeah, thank you, Dr. Rajendra Reddy.
Okay, good.
So, a brief introduction for Dr. Reddy. Dr. Reddy is the Rumi family president's Distinguished Professor of Medicine and Professor of Medicine in Surgery in the Division of Gastroenterology and Hepatology at the University of Pennsylvania. He is the Director of Hepatology, Medical Director of Liver Transplantation, and the Director of the Viral Hepatitis Center. He has held several visiting professorships at medical schools throughout the world. He has trained and mentored over the years several fellows and research assistants towards a career path in healthcare and research. Dr. Reddy has authored or co-authored about 480 peer-reviewed papers on a spectrum of hepatobiliary topics that include liver transplantation, chronic C viral hepatitis, acute on chronic liver failure, and hepatocellular carcinoma. In addition, he has edited and contributed to several textbooks and has participated in numerous scientific presentations at national and international meetings. He has been the recipient of both federal and non-federal funding for clinical research. And because of the time constraints he has, I think we will let him also participate in a focused 10-minute question and answer session after his presentation. Dr. Reddy, welcome.
Thanks very much. Can you hear me?
Yes, we can.
And you can see my slides as well?
Not yet.
Can you see them?
No,
No.
not yet.
Good. All right. Thanks very much for this invitation. Really my pleasure to be here to talk to you all about viral hepatitis. Try and give you all a brief overview in the 40 minutes that I have. Obviously, there are several areas that I won't be able to touch upon, but if there are questions, I'll be glad to answer them. So to set the stage, there are 5 viruses that we commonly talk about in the context of viral hepatitis. Mostly 4. There's the 5th one, Delta virus, which may or may not be seen in general practice. Nevertheless, I'll just briefly address it. So there are 2 non-enveloped enterically transmitted.
Dr. Reddy, I couldn't be able to see the slides. Can
You're not able to see the slides?
Yeah, can you share the slides, please?
Which I did. Hold on 1 second. Huh.
Vijay, can you share Dr. Reddy's slide? Possible? Yeah.
Can
Yes,
you see?
you can know. Now I can see. Thank you.
Yeah.
All right, good.
Thank you.
All right, let me see. All right, I started by introducing the 5 viruses that are commonly seen. 2 of them are non-enveloped enterically transmitted viruses, hepatitis A and hepatitis E. And then you have enveloped bloodborne pathogens, hepatitis B, C, and Delta virus. Delta virus may be something that is not seen commonly in practice. I suspect it is not. Nevertheless, I'll make a couple of points about Delta virus. So the next, what happened? Are you able to see the slides?
Yes.
So I want to talk a little bit about hepatitis A. This is something that we all are familiar with, particularly having come from India. Acute hepatitis A most often is a self-limited or subclinical infection. And most often people don't even know that they've been exposed to hepatitis A virus and they recover. For instance, people who are born in India and raised in India, like most of us, we would have an antibody against hepatitis A. By the age of 20, over 95%, close to 100%, would have developed an antibody. Nowadays, with improved hygienic measures, it may not be as high as what it will be in the people of our generation who came about several years back to this country. Now, the few clinical consequences are of fulminant hepatic failure, and fulminant hepatic failure can lead to death. Sort of very interesting in that children born to Indian parents here and visited India contracted severe hepatitis A. It's something that we neglect to keep in mind. They ideally should get immune serum globulin if they go to India, if they're born here. And I've seen several of those kind of cases as recent as the past couple of years where they've developed fulminant hepatic failure. And the older you are, when you're exposed to hepatitis A, the more likelihood of developing fulminant hepatic failure. Then unusual manifestations of cholestatic hepatitis characterized by jaundice and itching, relapsing hepatitis, where they seem like they're getting better and then have a relapse, and then occasionally hepatitis A may trigger autoimmune hepatitis, but most do recover. The diagnosis is pretty simple. Acute hepatitis A is diagnosed by the presence of antibody to hepatitis A virus of IgM type. IgG antibody indicates previous exposure and immunity. I made this point, again, if someone was born here and had not received hepatitis A vaccine, which incidentally is not given routinely, and they travel to endemic areas, they should really get immune serum globulin. This offers immediate protection. Now, if you want long-term protection where someone is going to an endemic area on a repeated basis, you need vaccination. And there are two FDA licensed vaccines, Havrix and Vacta. It's a 2-injection schedule, and they offer long-term immunity. Now, who do you normally vaccinate? I talked about travelers to endemic areas who go there repeatedly. Patients or individuals, I shouldn't say patients, who are working with non-human primates, they're at occupational risk for hepatitis A, they're vaccinated. Also, patients with chronic liver disease should be vaccinated because there are reports of severe hepatitis A in patients with underlying chronic liver disease. So it's routine practice and recommendation. And then patients who have high-risk behavior, men who have sex with men, it's recommended in them. Children in high-risk communities, and those who have hemophilia, et cetera, they should be vaccinated. But ideally, you really would want to vaccinate the entire population if you can. Now, I want to talk a little bit about hepatitis E. Some of you may or may not have heard of hepatitis E. It used to be called enterically transmitted non-A, non-B hepatitis, whereas hepatitis C used to be called parenterally transmitted non-A, non-B hepatitis until hepatitis C virus was discovered. And so that was labeled hepatitis C. And then enterically transmitted non-A, non-B hepatitis is now attributed to hepatitis E, which has been discovered. So if you were to look at hepatitis E, there are quite a few epidemics that have been reported around the world, and India is considered an endemic area for hepatitis E. And it kind of has similar clinical features as hepatitis A, except that it's a different virus. Back in the 1950s, there was an epidemic in Delhi of viral hepatitis. And it was thought perhaps that was hepatitis A, but stored sera from there subsequently it demonstrated that it actually was hepatitis E. But a better description of this epidemic was actually made in the Kashmir Valley back in the 70s. A very good investigator, Professor Kuru in Kashmir, described an epidemic of viral hepatitis that was distinct from hepatitis A. And when he first published his paper, when he first submitted his paper, investigators would not believe him, and so he had submitted the paper to Lancet. They didn't believe in this and being different than hepatitis A. So eventually he got it published in somewhat an obscure journal, American Journal of Medicine. Subsequently, there have been epidemics reported in Central Asia, Uzbekistan, Turkmenistan, and there have been reports in North American theater as well, and they've been described in Mexico and other countries. So now what we also learned is that there are several genotypes of hepatitis E, the genotype 1 and 2, which occur in epidemic form, and it's seen in the developing part of the world. It has a fecal-oral route of transmission, could be waterborne, and one distinction between this and hepatitis A is that there's a high mortality among pregnant women. They may have extrahepatic features, and there is a vaccine for hepatitis E, but it has only been approved in China and not elsewhere. Now, genotype 3 and 4 can be encountered in the US and is a sporadic form of hepatitis. Primarily, it's foodborne, and you can see it in people, in hunters who eat venison meat. Swine can be a host for this virus, and this can have a chronic manifestation, and it's primarily seen in immunocompromised persons, transplant recipients. We have done studies in transplant recipients. I think actually this fellow of Nagas, or colleague of Nagas, Niharika, who's done work on hepatitis E in transplant recipients. It can be seen, but rarely, and ribavirin is an effective treatment for chronic hepatitis E. But largely it is seen as an epidemic form and kind of resembles hepatitis A in clinical presentation. Let's switch gears and go on to hepatitis B. We have a large global population of hepatitis B infected individuals, and not all have evidence for ongoing hepatitis B infection. Most of them have evidence for past exposure to hepatitis B. And this can go on to chronic infection, and these patients can develop cirrhosis, liver failure, and liver cancer. So globally, there are estimated 400 million people with chronic hepatitis B. But as I pointed out, vast majority would have evidence for past exposure to hepatitis B. And there's a high mortality associated with hepatitis B. Now, if we were to look at geographic prevalence of hepatitis B, if we were to look at, say, for instance, India, it is in the 2 to 8% chronic infection prevalence area. North America, it's less than 2%, is actually 0.1 to 0.3%. In high-risk populations, such as IV drug users, men who have sex with men, it could be higher. A great part of hepatitis B is in Africa, sub-Saharan Africa, where the prevalence rate is greater than 8%. In China, it used to be high. Back in 2006, it was noted to be less than 8%, primarily because of vaccination strategies that were implemented there much earlier than other parts of the world. So globally, vaccination is what we need to have to essentially eliminate hepatitis B, but we have not really been great in accomplishing significant reduction in hepatitis B around the world, except in areas where they have universal vaccination. We should not be seeing cases of hepatitis B in the US now because we have vaccination strategies that start in infancy. So you don't see new acute cases or even chronic cases in young individuals unless they have somehow escaped a vaccination strategy. Now, serologic markers here are a little more challenging to interpret. So I'd like to give you all a bit of a overview of the serologic markers and as to how you should interpret them. Now, if you have no markers, surface antigen, an antibody to core, an antibody to core of the IgM type, and anti-HBs or antibody to surface antigen, none of these you have, you can clearly state that they've never been infected and that they've not been vaccinated. Now, if they just have antibody to this surface antigen, anti-HBs, that means they've been immunized. This is a response to a vaccine. Now, if you have antibody to core and antibody to surface antigen without surface antigen being positive, that means you've recovered from past infection and are immune. So the distinction between immunization versus natural exposure and recovery is that you have an antibody to core in those who have been exposed and recovered. Now, to diagnose chronic infection, you need surface antigen. Keep that in mind. Not uncommonly, people diagnose ongoing hepatitis B based on antibodies. Antibodies without surface antigen mean immunity. Okay, so make that very clear to your patients. Now, if you do have now the IgM type antibody to core along with surface antigen, that is acute infection. You don't have the IgM type antibody to core, but you have surface antigen, that means chronic infection. And sometimes you might see just an isolated antibody to core. It could mean past exposure with undetectable anti-HBs titers. It could mean a false positive test. Rarely, it could mean that there's ongoing infection. It's just that the surface antigen is negative, but that is rare. So I don't want you to tell your patients that it's possible that they still have an infective state. Antibody to core alone means exposure with recovery or false positive test. Now, there are various clinical profiles of chronic hepatitis B infection, but I just wanted to highlight a couple of the clinical profiles. Most important one is the inactive carrier state, where they have surface antigen that is positive, transaminase are normal, and they have very low viral DNA. And we normally now don't do a liver biopsy, but if they had a liver biopsy, it's normal. This is an inactive carrier state, and you're likely to see a lot of this in a fair number of your patients. Now, if you have very high virus, and your liver test is normal, surface antigen positive, and then there's E antigen that is a marker of active viral replication. This is an immune tolerant state. There is a nice symbiotic relationship between the host and the virus. High viral load, but no liver damage. But if they have high viral load, but there's some liver damage, as noted by ALT elevation and active histology, this is called an immune active state. And this is a kind of patient you would want to treat. And then there is a state called E antigen negative, but immune active state, where the ALT is elevated, virus is elevated, they have active histology. In essence, treatment is indicated for two categories of patients: immune active E antigen positive patients and immune active E antigen negative patients. It's also called pre-core mutant state. So, but in clinical practice, you're likely to see inactive carrier state more often. Delta virus is an incomplete virus. Delta by itself does not cause infection. It requires hepatitis B virus for replication and propagation. So don't diagnose Delta infection in someone who does not have surface antigen. So you need a surface antigen for Delta to replicate. Seldom seen, more often seen in intravenous drug abuser population. In certain populations, you can see it, and geographically it was first described in the Mediterranean region. So in Eastern Europe, there have been reports of more frequent Delta infection. Now, what is the natural history of hepatitis B? Well, you get infected. You may or may not develop acute B infection. I'll talk about this in a minute. But those who develop acute infection, depending on when they're exposed to the virus, They may go on to chronic infection. If you're exposed to this as an adult, you have a high probability of going on to chronic infection. Low probability of going on to chronic infection. If you expose this as a child, you have a high probability of going on to chronic infection. And then you have E antigen positive, E antigen negative chronic infection. And these patients go on to cirrhosis, go to hepatic decompensation, may develop liver cancer that may be associated with mortality, might be rescued with liver transplant. Now, what is important to recognize is that there could be a flare of chronic B hepatitis. That is something that's very critical. Nowadays, you see more often flares of chronic B hepatitis rather than acute infections. And this can be seen in patients who go on to cancer chemotherapy, who are placed on a variety of immunosuppressive drugs. Classic example is rituximab, that's given for a variety of reasons. And actually, you're expected to screen for hepatitis B if you were going to place someone on cancer chemotherapy or rituximab, because they can flare and you need to prophylax them with hepatitis B drugs to prevent a flare. So here, if you had vertical transmission from mother to child, and this can happen in places where hepatitis B is endemic, you can have a high probability of the infant going on to chronic infection. Well, but this should not happen nowadays. With vaccination, you interrupt the transmission from mother to the infant. So if this were to happen, that's really kind of sad, because globally, vaccine should be available to prevent this. Now, horizontal transmission can happen where there's someone who's already infected and they can transmit to anyone around in their household, or otherwise a healthcare worker can transmit. But all of these are theoretical, because a healthcare worker should have been vaccinated and not have ongoing infection. So the risk should be none from a healthcare worker. So here, if this happens, mother to infant, the probability of going on chronic infection is 90%. It could be lower, but here, horizontal transmission, the likelihood of chronic infection is relatively less. Now, there are vaccines. They've been around for quite some time. They've been around for almost 4 decades. I took the plasma-derived vaccine in the 80s, subsequently had recombinant vaccines available. It's a 3-injection schedule. Nowadays, there are combination vaccines of A and B. There are other highly immunogenic Prius vaccines that can be used for those who do not respond to standard vaccines. The older you are, the less the response. Obesity, alcohol use have been associated with suboptimal response. HIV infected individuals have had a low response. Now, the treatment for chronic hepatitis B, it is primarily suppressive therapy. There is really no quote-unquote cure for hepatitis B. And suppressive drugs are all oral drugs. They're nucleotide analogs, tenofovir and entecavir and tenofovir alafenamide are the recommended drugs. Tenofovir alafenamide is a prodrug of tenofovir. Interferon can be used. That nowadays it is not generally used. It's the oral drugs, and these are good suppressive drugs where they suppress viral DNA. Now, viral DNA suppression is in 90% of patients, but the next therapeutic endpoint would be E antigen seroconversion in the E antigen positive patients. And achieving these 2 endpoints will lead to improved histology. Loss of surface antigen is seen in only about 5% of patients. A fair number of patients, you just suppress virus. This loss of E antigen with appearance of E antibodies, about 30% of patients. And you achieved these endpoints, you obviously will improve survival. So most often, the second and third endpoint do not occur. So you basically end up treating them long-term with oral suppressive therapy. This is pointed out, loss of surface antigen with appearance of surface antibody. It happens in only about 5% of patients. Hepatitis C is the more common infection that practitioners encounter in their practice. Globally, there are estimated 170 million people believed to be infected with this virus. In America, it's anywhere from 2.7 to 4 million people who were believed to be infected with the virus. Fair number of them have been treated, yet there is still quite a high prevalence of this infection. Now, this has a greater propensity to go into chronic infection, unlike hepatitis B. Where with hepatitis B, it's, as I pointed out, 5% or a little higher in adults who are exposed to B virus, but here it is much higher regardless of the age of exposure. It could be as high as 85%. There's a risk of cirrhosis of about 30% at 30 years, and there is cirrhosis associated with mortality. And right now, the leading indication for leading predisposing condition for primary liver cancer is hepatitis C related chronic liver disease, although in time, non-alcoholic fatty liver disease may take over. Now, some of you may or may not know this. Last year, the Nobel Prize in medicine was awarded to those who played a major role in the discovery of hepatitis C virus. Michael Houghton worked at a small company called Chiron Corporation and was instrumental in developing antibody assays for diagnosing hepatitis C. It was through ingenious molecular biology technology that they discovered. Harvey Alter is at the blood bank in the NIH and provided sera, well-pedigreed sera, that apart from sentinel work in the field of non-A, non-B hepatitis, provided sera to Michael Houghton that formed the basis for validation of his assays. And Charlie Rice at Rockefeller Institute developed a cell culture system that accelerated drug development for hepatitis C. So it's an incredible story, having been in as a hepatologist for about 38 years. I've seen the story come a long way from the days of non-A, non-B hepatitis to the days of hepatitis C, viral discovery and development of drugs. So I talked about the natural history of this. I don't think I need to go into this, in that hepatitis C can go into chronic hepatitis, cirrhosis, end-stage liver disease, and liver cancer. Now, apart from liver-related complications, you have to keep in mind that there are extrahepatic manifestations related to hepatitis C, and it pretty much can affect any system. It could be hematologic extrahepatic manifestations, dermatologic. There could be renal, such as glomerulonephritis, nephrotic syndrome. It could be necrotizing vasculitis, polyarteritis nodosa. There might be neurologic manifestations. And there are a couple of examples here of a patient with maculopapular rash that was seen in the context of hepatitis C. And once hepatitis C was treated, this manifestation disappeared. Here's a patient with blistering eruption on a hand, which is porphyria cutaneous tarda, that can be seen in the context of hepatitis C infection. And we do have effective therapies. There are 6 main genotypes of this virus. We have pan-genotypic regimens. These therapies are extremely well tolerated. Greater than 90% probability of sustained virologic response. Here, hepatitis C can be cured. It is not just suppressive therapy. Regimen can be as short as 8 weeks, and frequently for certain situations may need to go up to 24 weeks. And it's just the best treatment is 1 pill a day for 8 weeks, and you have a high chance of cure. So this is a really remarkable story when it comes to drug development for a major condition. And these are generic drugs that are available around the world. While the treatment is expensive in the US, generic drugs are available in various parts of the world. For instance, in India, these are drugs that I got from Myanmar. It's less than $100 that you can get a course of treatment and can effectively treat hepatitis C. And there are clearly benefits to curing hepatitis C. This is based on a VA study. If you were to look at patients who achieved sustained virologic response, as noted by this blue line, relative to those who did not achieve sustained virologic response. There are very few do not achieve sustained virologic response. This was in the days when we had suboptimal responses to interferon therapy. What you see here is overall survival in those achieved sustained virologic response was better than those who did not achieve sustained virologic response. And then liver cancer disease-free survival was also the highest or higher in those achieved sustained virologic response. And in those with non-advanced chronic liver disease, also there was a better survival. But if you were to look at those who had more advanced chronic liver disease, that is cirrhosis, as noted by this FIB4, or they also had bridging fibrosis, it was more profound. The benefit was those who had milder form of liver fibrosis, the benefit was not as profound. But regardless, overall benefit with cure and fewer liver cancer related events or and death in those with a cure. Well, it's all great. Well, hepatitis C should not be a problem, right, in the immediate future. But sadly, it is a global problem. You know, WHO a few years ago had set some targets to define elimination, and it's felt that we could achieve elimination by 2030. The 2030 targets established by WHO are that globally 90% of cases of hepatitis C would have been diagnosed, 80% treated, 65% would have, there would be a 65% reduction in mortality, and that there would be a 90% reduction in HCV incidence, that is 90% reduction in acute hepatitis C. Well, sadly, globally, most countries are not on target. And you can see these red areas depict countries that are not on track to achieve WHO goals by 2030. Sadly, even the US is a country where we're not on track to achieve the WHO target. The ones who are on target are working towards it is Australia. You know, Australia has closed, I guess, ocean barriers. There's no influx of populations. That may be one reason, but they do have a very good screening and treat program. Very interesting. Egypt has a very aggressive screening and treat program. They go into villages and then do have mass screening and then just give them a course, 8-week course of therapy. There's no need for follow-up, even in these patients, recognizing that over 90% achieve sustained virologic response. Some of the Scandinavian countries may be on track, but sadly, most countries are not on track. And then now we do have a pandemic of SARS-CoV-2, and that has actually delayed diagnosis and treatment of hepatitis C. So resources have been shifted towards COVID-19 care. and as such, hepatitis C therapy is further being delayed. So there is a lot of talk about recalibrating the target timelines, and it may be that we would need to go to 2051 to expect reaching these targets. Lastly, I want to talk about the new kid on the block, SARS-CoV-2. There's a lot of talk about SARS-CoV-2 virus causing liver injury. What is known thus far is that the liver, biliary epithelium and liver cells have this receptor called angiotensin converting enzyme 2, to which the SARS-CoV-2 virus has affinity. So theoretically, one would say that they could develop severe hepatitis. It's abnormal liver tests have been seen in about 14 to 53 or 55% of individuals with COVID-19, primarily AST and ALT elevation marginally. Elevated bilirubin is less common, but what I want to emphasize is that there is no evidence that SARS-CoV-2 causes this viral hepatitis. What you see is actually phenomenon as part of multi-organ failure. It's not uncommon to see abnormalities in liver tests, say in someone who has pneumococcal pneumonia or urinary tract infection. So this is a non-specific manifestation associated with COVID-19 rather than a specific viral infection of the liver. Although there are rare cases of severe acute hepatitis described, I believe this is these are manifestations of a systemic illness rather than direct liver infection by SARS-CoV-2. Something that you need to keep in mind. So to summarize, hepatitis A and hepatitis E viral infections continue as acute infections. You can see chronic E in the US or some other countries due to genotype 3 or 4, but in endemic areas, both A and E are seen as epidemics rather than sporadic cases. And there are no chronic hepatitis A cases, so please do not tell your patients that you have chronic hepatitis A infection. Similarly, people coming from endemic areas, they do not have chronic hepatitis E infection. Hepatitis C and B are chronic infections. Vaccines exist to prevent these infections. Hepatitis B viremia can be controlled or suppressed, but it's not cured. Hepatitis C infection can be cured. Sadly and paradoxically, while we have great treatments, inexpensive drugs, we have not achieved major success in treating a large number of the infected individuals. So we need to really make an effort towards screening and treating hepatitis C patients. In the US, it might be an expense issue, but the rest of the world, expense should not be a concern. So with that, I will stop and take some questions, if I may. Thanks very much for your attention.
Yeah, thank you. Thank you very much, Dr. Reddy, for this authoritative talk on a topic which is equally important to our Indian guests. We really appreciate your presence here today. Now, in light of the time constraints, what we can do is over the next 10 minutes or so, Dr. Janlagada is going to moderate the session for questions and answers. I'm sure I've seen a lot of questions coming up there. So you got about 10 to 12 minutes to answer the questions. And after that, and I know you're in a hurry to leave us, so we have the responsibility. We are honored to have you here today. And Dr. Sajani Shah, she is the chairwoman for the AAPI Board of Trustees. She will be honoring you, and the rest of the speakers will be honored at the end of the workshop. Thank you, Dr. Janlagada, you're on.
Thank you, Dr. Reddy, for eloquent talk, as always, and a pleasure having you today. And I have a first question for you from the audience. This hepatitis B vaccine, 3 doses. After giving these 3 doses, one should get immunity achieved or not?
So the question is, I'm sorry, I got a call. And hepatitis B vaccine. How sure should should one be about immunity? Okay, so as you all know, if you get your children get vaccination, there is no follow-up of testing in terms of antibody, because overwhelming majority of children develop a good response. And then as time goes by, even if their titer goes down of antibody, they should have what you call T cell memory. So if they're exposed to B virus, there is an anamnestic antibody response, and they are protected. Now, the ones who really should be tested for antibody are the ones who are at high risk for not generating an antibody response. So someone was to be vaccinated, say, at an age above 50, theoretically, they may not have an antibody response. I talked about the HIV infected person. Patients with liver disease, they may not develop an antibody response. If it's a healthcare worker, you were vaccinated at an age beyond 50 or obese or drink alcohol, you should test your antibody. And if you have an antibody response right after vaccination, you don't need to have your antibody tested subsequently. As I pointed out, there you'll have an anamnestic response if you're exposed to the B virus. So you should be protected even if the titer goes down. So generally speaking, antibody testing is not recommended unless you fall into the category where you are likely to have less response to vaccination or lower rate.
Yeah. The next question, you all know that we have a better treatment of hepatitis C, going from monotherapy to the combination now. Coming to the hepatitis B, current treatment was not able to eradicate the infection. And is there any combination trials ongoing now?
For hepatitis C?
B.
Well, there are lots of drugs, that are trying to get to, I guess, the foundation of the virus. The foundation of the virus is something called covalently closed circular DNA, cccDNA. That is the template for viral production, and it's somewhat integrated in the hepatocyte, so in the nucleus. So they're working on drugs to get to the foundation or the factory of the virus. They're all in phase 2 right now. It's a very tough virus to crack. So there's nothing in phase 3. There are a lot of drugs that have really hit the graveyard, so to speak. So right now, you're still looking over the next 5 years at suppressive therapy rather than quote unquote cure.
Okay, thank you. Coming to the patient or hepatitis, are the risk for COVID infection?
Okay, so actually, I wrote a paper on this. So it's not a question of whether they're risk for COVID. I mean, their risk for COVID should be the same as the general population. The question is, are they at risk for severe COVID? Okay, so there's nothing about hepatitis B that tells you that, hey, listen, they have a greater affinity for SARS-CoV-2. But if they do develop, will they have severe manifestation? And that is not clear. At the current time, there's no data to suggest that hepatitis B patients are at risk for severe COVID. What is very interesting is, well, similarly, I can address this. Well, you would think theoretically that liver transplant recipients or those who are immunocompromised are at risk for severe COVID. That's a myth, not a reality. This likelihood of severe COVID-19 in transplant recipients is the same as in the general population. There was a very nice study that looked at liver transplant recipients and compared them with the contemporaneous cohort of non-liver transplant recipients who had COVID-19, and the mortality was similar, 28 versus 27%. So that's really a myth. Cirrhotics who develop COVID-19 are likely to have more severe disease and poorer outcomes compared to COVID-19 alone.
The next question is somebody on treatment for hepatitis B or C, if they get infected with COVID, do they continue treatment for B and C, or they stop the treatment while they're getting treatment for COVID?
No, they should be able to continue the treatment because they're all oral drugs. Well, they're oral drugs for both conditions, and really should not present a challenge. It's a question that comes up, but I don't see a need to interrupt because they're not hepatotoxic drugs. They don't have any adverse events on a lung manifestation. So, no.
Yeah. Is there any ongoing trials for hepatitis C vaccination?
Well, no. Well, people have tried hepatitis C vaccination, and in animal studies, it's shown to not necessarily prevent, but if you're exposed, the animals exposed to hepatitis C virus, they had a subclinical manifestation. So one has to broadly look at hepatitis C vaccination development as the challenges with HIV. HIV has been around there for a long period of time, right? So why don't we have a vaccine against HIV? The same thing, it is a heterogeneous virus, and there are multiple epitopes of the virus. So if you develop or produce an antibody, by the way, these are not neutralizing antibodies that they generate, you're not likely to protect someone from other epitopes or other protein fragments of the virus. So development of a vaccine for hepatitis C has been challenging, and it is somewhat similar to developing a vaccine for HIV, the same challenges.
Okay. Thank you. One more question is for hepatitis B patients, in how you treat with the pregnant and other inflammatory bowel disease patients?
Hepatitis B?
Yeah.
Patients, pregnancy?
Yeah, in pregnancy and inflammatory bowel disease, IBD.
So pregnancy, basically the drugs, the two drugs, tenofovir and tenofovir alafenamide, that can be used safely in pregnancy and can be used, but you have to have the same indications that I pointed out to treat hepatitis B in pregnancy. You do not treat a carrier. You do not treat someone who has very low viral load. Immune tolerant patients, generally, as I said, you don't treat, but in pregnancy, they have viral load greater than 200,000. In the third trimester, it's recommended that you treat them because it's been shown that treating high viral load state in the third trimester decreases the transmission of hepatitis B to the neonate. It's been shown in China that high viral load mothers, despite vaccination of the neonate, transmitted hepatitis B to the neonates. And in a randomized trial, those mothers who received hepatitis B therapy in the background of high viral load transmitted to a lesser rate hepatitis B to the neonates. Of course, they all should get vaccination.
How about inflammatory bowel disease? Sam?
I have no reason to believe there's a contraindication for use of hepatitis B therapy in inflammatory bowel disease. By the way, there was someone is asking, GSK drug, is it really close to functional cure? Well, I hope it happens in my lifetime. We've been working on this functional cure for about at least half a decade or more. And they're all in phase 2. And as I pointed out, several hit the graveyard already. There probably has to be a combination treatment. There's several steps in hepatitis B viral replication, and all these companies should kind of come together and work on multi-drug, multi-targeted therapy to achieve the functional cure.
A last question, and what hepatitis B patient will not do surveillance ultrasound?
Hepatitis B?
Yeah.
Everyone should have surveillance ultrasound for cancer as a rule. this is independent of cirrhosis. For hepatitis C, it's only the patients with cirrhosis who are at risk for liver cancer, and you do not need to do surveillance on someone who does not have cirrhosis. Hepatitis B, patients who come from endemic areas, who have perinatal transmission, I do surveillance early on, although if you look at the data, cost effectiveness strategy, it is recommended for women about the age of 50, men about the age of 40, for African men about the age of 20. So when I say all patients, it's primarily anyone who has hepatitis B infection and has come from an endemic area. Should really have surveillance regardless of whether they have cirrhosis or not. That's my way of looking at it. But if you were to look at guidelines, strict cost-effective strategy, it is men about the age of 50, women about the age of 50, men about the age of 40, and Black American men about the age of 20. And of course, if they have cirrhosis, they do meet criteria for surveillance.
Thank you very much, Dr. Reddy, for excellent presentation. I request Vijaya Kodali, please post the plug, please, and Dr. Sajni Shah.
All right. Thanks very much. Appreciate it.
Yeah.
Thank you.
All right. Good luck. Take care.
Thank you.
Bye.
Bye, Raj.
Bye, Naga. Thanks so much. I'll talk to you.
And if you can wait for 1 minute, I think we are going to recognize you with the plaque,
Oh, okay. Thanks.
and you are being inducted into the Distinguished Speakers Club of AAPI. Just 1 minute, please. Thank you. Dr. Janlagada, Dr. Sajni Shah is here.
Yeah, supposed to be. Dr. Sajni?
Okay. In light of time, I think
Hi guys, sorry.
Yeah.
Can
go
you
ahead.
hear me?
I got
I'm
you.
having some issues with my
No,
internet.
that's okay. Well, that's what I thought. Go ahead, please.
Can you guys hear me?
Yep.
Yeah.
Yes.
Great. I just wanted to thank everybody for this wonderful talk on an early Saturday morning. I'm also a bariatric surgeon, so talking and listening about liver disease and NASH and the benefits of weight loss and bariatric surgery is really important. And I think you couldn't have said it any better in terms of the risk that you sort of have to outweigh whether these patients will succumb to the disease or will they have complications from bariatric surgery, which will also have an unfavorable outcome. So I really appreciate the talk. It was phenomenal. And I look forward to the rest of the talks today. So thank you.
Thanks so much.
Thank you. Vijaya, can you post the plug again, please? American Association of Physicians Indian Origin recognized Dr. K. Rajendra Reddy, MD, for his outstanding contribution to hepatology and welcome him as a member of AAPI Distinguished Speaker Club. Sudhakar Janalagada, President AAPI, and Dr. Vemur Murthy, Chairman AAPI Webinar CME Committee, January 23rd, 2020. Thank you very much, sir. Thank you very much. We'll mail this plug to you soon.
All right. Thanks, Sudhakar.
thank
Okay.
so much.
Enjoy.
Yeah.
Bye now.
Yeah, I'm happy that I think, we are right on the target, time-wise. So now it is my pleasure to introduce our third distinguished speaker, Dr. Eric Scott Orman. Dr. Orman is an assistant professor of medicine, Division of Gastroenterology and Hepatology at Indiana University School of Medicine, Indianapolis, Indiana. He authored a number of publications in the field of gastroenterology and hepatology, contributed to various peer-reviewed journals, such as Annals of Internal Medicine, conducted groundbreaking studies in hepatology, and mentored a number of fellows. Thank you, Dr. Orman, for joining us today. You're on.
Thank you so much. Appreciate the invitation to speak today. Can you hear me okay?
Yeah.
Yes.
Perfect. I'll share my screen here. Thanks for just a moment. Great. So I'll be discussing the common complications of cirrhosis this morning. This is a topic that's pretty near and dear to my heart. This is my area of research interests, and practicing at a busy liver transplant center. This comprises quite a bit of my clinical duties. It's a big challenge, and it can be pretty complicated taking care of patients with multiple issues going on. But I hope this can be helpful, sort of lay out a framework for how to think about some of the common cirrhosis complications. Main learning objectives this morning, to recognize these complications and how they can impact the prognosis for cirrhotic patients, to understand the diagnostic evaluation of cirrhosis complications, and then how do we manage these common complications. So I'll largely be talking about these three complications: ascites, hepatic encephalopathy, and variceal bleeding. And we're talking about these three in particular because when we talk about cirrhosis, and we often categorize patients into having either compensated or decompensated liver disease, we're really referring to whether or not they've had one of these complications. So patients who haven't had a complication, one of these three complications, we refer to as compensated. And once they've developed these issues, they're then decompensated or have end-stage liver disease. And that's when really a lot of the bad things can happen to them. And actually, cirrhosis is the 8th leading cause of death in the United States. And so these complications, the presence of them, the number of complications, and their severity are really the main indicators of an individual patient's prognosis. So as I mentioned, compensated versus decompensated cirrhosis, whether or not you've had any of these complications, really significantly impacts mortality. Any one of these complications in your decompensated cirrhosis, your survival is much worse than patients who are otherwise well compensated. And once you've had decompensated cirrhosis, the median survival is only about 2 years. So we'll often start thinking about liver transplant in patients once they've developed these complications, just because the long-term prognosis is so poor for patients. Thinking about not just the presence of any complication, but also the individual complications and their severity and how they weigh into to our prognostic scoring. The Child-Pugh score has been around now for 50 years or so. We still use it quite frequently in clinical practice. And it's based on 5 simple variables, 2 of which are these complications of ascites and encephalopathy. And we score them based on how poorly or well controlled they are. And 1 and 2 year survival is directly related to the presence of these different levels of ascites and encephalopathy. And if you have child class C cirrhosis, median survival is only about a year. So these are really, really closely tied to mortality. So I'm going to speak on each of these 3 issues, and we'll start first on ascites. Before we talk about cirrhotic ascites, it's important just to recognize that not all ascites is due to liver disease. Cirrhosis is the #1 cause of ascites in the United States, but there are other factors as well, and you don't want to lose sight of that in a patient who's presenting for the first time with ascites. Of course, you have to think about potential for cancer, carcinomatosis, other conditions like heart failure, renal failure. Rarely infections like tuberculosis can also cause ascites. And so how do we sort out the underlying cause of ascites in a patient with a new presentation with ascites? Well, you have to do a paracentesis. That's really critical. And I'm going to keep harping on that in my discussion this morning, how important it is to do diagnostic paracentesis. When you do a diagnostic paracentesis, you can send off, the lab will allow you to send off a ton of things, but really you can get 90 to 95% of the way towards a firm diagnosis, really just by getting ascites albumin and total protein. Just with those 2 tests, you're going to get most of your diagnostic information. And you can calculate the SAG, the serum ascites albumin gradient. It's very simple. You just subtract the serum albumin minus the ascites albumin, and you get the difference, which is your SAG. When you have a low SAG ascites, that can, and we use a threshold of 1.1, that can indicate non-liver related conditions like cancer or renal failure. When you have an elevated SAG, so you have a large gradient between the serum and ascites albumin, that's more suggestive of either cirrhosis or heart failure. And then you can further look at the total protein, keep in mind that cirrhosis, ascites from cirrhosis is typically associated with low total protein. So a high SAG and a low total protein, less than 2.5 is our typical cutoff. That's highly suggestive of cirrhosis and portal hypertension versus heart failure, which tends to have a higher total protein content. The other and third important test that we'll often get when doing a diagnostic paracentesis is the cell count and differential. And this is critical, especially in patients with cirrhosis, because you don't want to miss SBP. So I want to talk a little bit now about spontaneous bacterial peritonitis. The diagnosis, this again is a diagnosis that's made from analyzing ascites fluid and looking at the cell count. And when there's greater than 250 neutrophils, then that's diagnostic of SBP. And that can be with or without a positive ascites culture. So we often, very commonly diagnose SBP in the absence of a positive culture. And often that's due to patients having already received antibiotics. And sometimes even without antibiotics, the cultures will come back negative. But really you're looking at that cell count as being the critical piece of information for diagnosis. And the pathophysiology is pretty complex, but essentially what happens in end-stage liver disease is patients develop bacterial overgrowth. You can see here in this cartoon on the right with worsening liver disease. They develop epithelial tolerance so that bacteria can translocate across the epithelium into the peritoneal space. And then you have immune paralysis, or just a poor ability of the immune system to clear bacteria from ascites. And then you can develop, the bacteria can set up shop and essentially cause uncontrolled infection. You really need that paracentesis. Again, I'll harp on that. The clinical impression of SBP is really poor. This is from a series of patients presenting to the emergency room with ascites and looking at those, comparing those with and without a final diagnosis of SBP. You can see that the difference in some of the signs and symptoms are minimal. So it's very difficult to say, in the absence of fever or the presence or absence of abdominal pain, whether or not a patient may have SBP. So you really, again, I'm going to harp again, you need to get that paracentesis because clinical information isn't going to necessarily give you the information you need. So in that same group of patients who came to the ER, this is a great study. I really enjoyed this study. They asked the physicians whether or not, really experienced physicians, whether or not the patient warranted diagnostic paracentesis. In the majority of patients, they felt that they did need a diagnostic paracentesis. But their assessment of whether they needed one really didn't correlate very well with the final diagnosis of whether they had SBP or not. And importantly, I just want to focus on this area. These were patients where they ended up having SBP, but the physician felt that no, they didn't need a paracentesis. And that was the case in more than 20% of patients who ultimately did have SBP. And you just don't want to miss this group because when treating any infection, SBP included, time is of the essence. When you look at patients presenting with sepsis from any cause, every hour delay in getting effective antimicrobial therapy is directly related to reduced survival. So you want to make the diagnosis as quickly as possible. You want to get antibiotics on as quickly as possible. And ideally, you want to have that paracentesis before the antibiotics are given so that ideally you want to get that culture data that's going to help drive your antibiotics and decision-making. And this translates to the early antibiotics also translates into the quickness with which you can get a paracentesis. So looking at patients hospitalized and looking here on the left at the time it took for them to get a paracentesis, patients who didn't get a paracentesis for more than 48 hours after admission had nearly 4-fold increased mortality compared to those who had a prompt paracentesis. So this really underscores the importance of getting a quick paracentesis to make a diagnosis first, of course, and then also to guide therapy. And we did a study a couple of years ago looking nationwide at all hospitals across the US, and of patients who should have a paracentesis, otherwise eligible, actually only about 2/3 of them had a paracentesis during their hospitalization. And interestingly, those who did have a paracentesis actually had reduced mortality by about half. So that just speaks to how important getting that paracentesis is. So bottom line is patients hospitalized and has ascites, they really need a paracentesis, and the sooner the better. Sometimes this comes up actually fairly frequently, especially in patients with end-stage liver disease who often will have pretty significant thrombocytopenia or coagulopathy with an elevated INR, is the risk of doing a paracentesis, and is it safe, and in particular the bleeding risk. It turns out though that paracentesis is actually very safe, and here's 3 series looking at the safety of paracentesis, and looking at hundreds and even at thousands of patients, the risk of significant complications is very, very low. Bleeding in particular, the risk is very low. And the other thing to drive home is, importantly, the bleeding risk didn't seem to correlate with levels of platelets or with INR. So even platelets with significant coagulopathy, their risk of bleeding from a paracentesis is no greater than those who have preserved coagulation. So overall, just generally speaking, the benefits almost always outweigh the risk of doing a paracentesis in these patients, and doing it promptly. And the reason, again, when you want to diagnose SBP quickly in a patient with ascites, you want to get appropriate antibiotics on quickly. That's going to improve outcomes for patients. So when you do make the diagnosis, which antibiotics do you use? Classically, we've relied on cephalosporins as first-line therapy for SBP. We still do in the majority of patients, but it's important to recognize that patients with healthcare-associated and nosocomial infections are at much higher risk of bacterial resistance. And a lot of our patients with end-stage liver disease have a lot of healthcare contacts. You know, it may be that they're coming in for regular paracentesis, or they've had admissions for hepatic encephalopathy. So they often do have a healthcare associated infection. And in these patients, we're also thinking much broader spectrum antibiotics, just because of the risk of antibiotic resistance. So we'll often use a broad spectrum gram-negative coverage. We use quite a bit of Zosyn at our center. And there's also a significant risk of gram-positive bacterial infection with SBP. So not uncommonly, we'll add gram-positive coverage as well. When you're giving antibiotics in the setting of SBP, it's important not to overlook the benefit of giving albumin as well. This is now a study that's now over 20 years old, but it's become essentially standard of care, at least at our center, to give albumin during the course of SBP treatment. This was a randomized trial where patients received either antibiotic alone or antibiotic with albumin. Patients who received albumin in addition to antibiotics had significant reduction in both in-hospital and 3-month mortality. And a lot of that reduction in mortality was related to prevention of renal failure, which is pretty common in the setting of SBP. We'll talk a little bit later about hepatorenal syndrome, but infections such as SBP are often a trigger for renal failure and hepatorenal syndrome. Beyond diagnosing and treating SBP, because it's such a common infection in patients with end-stage liver disease, many patients also warrant prophylaxis, and that can either be primary prophylaxis in patients who haven't had SBP before, and then of course, patients who've had SBP are at much higher risk of subsequent infections, and secondary prophylaxis is also recommended. Those who have not had SBP in the past, we recommend primary prophylaxis generally in those who have low protein ascites, which is less than 1 gram per deciliter. You'll remember that I mentioned earlier, cirrhotics typically have a low protein ascites. And then the other important group of patients that you want to make sure they get prophylaxis in the setting of GI bleeding. Talk a little bit later about that as well, but antibiotics are a central component of treating patients with cirrhosis presenting with GI bleeding. On the right here, I've listed common antibiotic choices that we give for SBP prophylaxis. Often we'll do fluoroquinolone either daily or weekly dosing. Generally, guidelines recommend against weekly dosing, but it's still pretty commonly used in the community, and it's also been supported by studies in the past. Bactrim is another choice. And then in the setting of someone who's hospitalized with GI bleeding in particular, we'll often use a cephalosporin. And these therapies are highly effective. They improve mortality. And there's not a whole lot of things that can improve mortality in this group of patients who are really sick. But patients who are ambulatory who receive SBP prophylaxis, here's a meta-analysis results on the left showing reduced mortality in that group. And then here on the right showing a similar forest plot of a meta-analysis, again showing reduce mortality in the setting of GI bleeding when you give prophylactic antibiotics. So moving beyond SBP and just general treatment of ascites, this is the mainstay of the initial treatment of ascites. Number one, before you get to the diuretics, you always want to give patients good instructions on sodium restriction. And I'll often refer patients to a dietitian to get a little bit more in-depth counseling. It can often be, patients often have a difficult time adhering to a low sodium diet, particularly with a common Western diet among many of our patients. And with that, we'll do a diuretic regimen. Usually it's a combination loop diuretic, aldosterone antagonist. The common starting dose, this is a common starting dose here, Lasix 40 milligrams, spironolactone 100 milligrams. Usually that's where we start. Often, sometimes we'll start with a lower dose though in patients who have underlying renal insufficiency, pre-existing electrolyte abnormalities, or older patients who may not tolerate these doses as well. And then thirdly, you want to avoid any medications that could make ascites worse, in particular NSAIDs. It's actually a pretty common misconception in patients when I meet them who've previously been diagnosed with cirrhosis, who've been told or researched themselves and decided that they couldn't take any acetaminophen for pain. And I have to really dispel them of that notion, because they'll often use a lot of NSAIDs instead. And NSAIDs really are contraindicated in the setting of ascites. And acetaminophen at low doses is safe. Usually I'll recommend patients take no more than 2 to 3 grams per 24-hour period. Depending on other underlying comorbidities, you also kind of want to rethink the use of ACE inhibitors that can decrease renal perfusion, potentially making ascites worse. So that again can be you may want to reconsider antihypertensive regimens in patients with ascites. And often in these settings, patients are starting, their blood pressures are starting to fall anyway. So paring back on some patients' hypertensive regimens may be appropriate. Pathophysiology of ascites is pretty complex, but it all relates to portal hypertension. That results in systemic vasodilatation, which reduces the effective arterial blood volume to the kidneys, and then you get renal sodium retention, fluid retention, ascites formation, and you end up in this vicious cycle. And then with worsening portal hypertension and worsening vasodilatation, you can get to the point where you develop refractory ascites that's no longer responding well to medical therapy. And then kind of the end stage or worse, most severe presentation of this would be hepatorenal syndrome. And so refractory ascites really refers to two different, we can kind of conceive them in two different ways, although we essentially treat them the same. One is diuretic resistant ascites. These are patients who are on a good, solid diuretic regimen with a good sodium restriction, and then diuretic intractable ascites, those who are not able to take an effective diuretic dosage due to complications. And I've listed some of the complications here at the bottom. Frequently, patients on these diuretic regimens will develop renal impairment, electrolyte issues, and these can all worsen the risk of hepatic encephalopathy. So it's not uncommon for patients to be limited in their diuretic usage due to these other concomitant issues. Treatment of refractory ascites. Initially, we typically rely on large volume paracentesis, and that can be done repeatedly depending on the frequency of reaccumulation of fluid. For patients who are getting a large volume paracentesis, and in particular greater than 5 liters at a time, those rapid fluid shifts can result in what we call post-paracentesis circulatory dysfunction, where you essentially can precipitate worsening renal function. And so we often will give patients IV albumin to prevent that, and that is effective in preventing renal failure and preventing hyponatremia, which are some of the kind of longer term issues from paracentesis. It's really in this group where, if they are eligible, then you want to consider either liver transplant or TIPS. These are the patients who are getting worsening portal hypertension, and need to be thinking about advanced therapies. Again, hepatorenal syndrome is sort of the most critical end stage of this of portal hypertension. It again relates to arterial vasodilatation, decreased effective arterial blood volume to the kidneys, and the kidneys in response have overexuberant vasoconstriction, and that results in decreased renal perfusion, which leads to renal failure. It's important to remember that not all acute kidney injury in the setting of cirrhosis is due to HRS, due to hepatorenal syndrome. That's really important because hepatorenal syndrome, as I'll talk about in just a moment, has a very, very poor prognosis without transplant. And so you want to be sure there's nothing that you could correct potentially. Here's results of a large series of patients with cirrhosis who were hospitalized with acute kidney injury. And HRS actually only accounted for about 10% of acute kidney injury. It was much more common for the renal failure to be due to either an infection or pre-renal azotemia. So you want to be sure that you've addressed any potential infections or pre-renal. And HRS, and you sort of do that when you're making the diagnosis of HRS. It is a diagnosis of exclusion. It only occurs in patients with cirrhosis and ascites, and that's a critical piece. Sometimes we'll see patients labeled as hepatorenal syndrome just because of underlying liver disease, but without ascites. And really that can't be the case. If there's a patient without ascites and renal failure, you really need to be thinking otherwise when hepatorenal comes up. And you don't want to just make that knee-jerk diagnosis. But certainly they have to have acute kidney injury. Generally we'll hold diuretics on these patients and give them an albumin challenge to exclude any component of pre-renal azotemia and to give them to improve their renal perfusion. Of course, you want to make sure there's no shock, other nephrotoxic drugs, or any underlying other causes for kidney injury. It's important, again, to make the diagnosis clear because the prognosis is so poor. And then in particular here, looking at the dotted line on this survival graph, this is referring to the classic type 1 hepatorenal syndrome, where you have a rapid progression of renal failure with a high creatinine in a short period of time. And that's associated with very, very poor prognosis. We're talking in weeks here. And really, these are the patients you want to be getting to a liver transplant center as quick as possible. The medical treatments are limited for hepatorenal syndrome. As I said, you want to make sure they get to a liver transplant center, but most of them are focused on counteracting that systemic vasodilatation. So these are all generally focused on peripheral vasoconstriction. Terlipressin is a vasopressin analog. It has the most data for hepatorenal syndrome, but it's not available in the United States. Usually in the United States, we rely on a combination of midodrine, octreotide, and albumin. Again, trying to improve renal perfusion through volume resuscitation and counteracting that vasodilatation. However, these therapies are all, I sort of think of them as Band-Aids. Really, the end game here is can the patient get a transplant? Because otherwise, as I mentioned, the prognosis is quite poor. So that was ascites, kind of the whole run of ascites, really, from most mild to most severe. And now I want to talk a little bit about hepatic encephalopathy. And HE is really, it's a spectrum of neurologic condition. It ranges all the way from very mild changes to mental status, all the way to a patient who's comatose in intensive care. And we see that here. We use the West Haven criteria for grading. We've been using this for years, but just to go through them, grade 1 are patients you may see in the office who have subtle changes, potentially subtle changes in behavior or in personality, or have a shortened attention span or slight lack of awareness. They often don't recognize it themselves. That's often brought up by their loved ones when you're seeing them in the office. Grade 2 are the more overt changes where patients are clearly disoriented to time or place. They have more aggressive personality changes and inappropriate behavior. These are patients you may see in the office who you might want to admit to the hospital potentially, or you may see them in the hospital already coming through the emergency room brought by a family member. Grade 3 are patients who are more somnolent but can be aroused. And then grade 4 are comatose patients. So it really is a whole spectrum. And we're recognizing more and more there's even earlier stages than the clinical stages that we've recognized for so long. There's a condition called minimal or subclinical hepatic encephalopathy. And that's not detectable at all clinically, but if you subject patients to detailed neuropsychologic testing, you can find deficits in attention and executive function. The pathophysiology, of course, ammonia, we all know, is an important component of the pathophysiology of encephalopathy, but it's not just ammonia. Ammonia is important, but it's not the only thing. There's also a contribution of low-grade cerebral edema, astrocyte swelling, alterations in the presence of neurotransmitters and their receptor expression, and then altered metabolism of glucose in the brain as well. So we do use ammonia quite a bit. It's used quite a bit in the community as well in terms of helping to make a diagnosis and treatment of HE. But truthfully speaking, it's quite limited in how much information ammonia can give you. You can see here ammonia levels across a spectrum of hepatic encephalopathy. And certainly elevated ammonia is associated with worse presentation of HE, but you can also see there's quite a bit of overlap. So patients who have pretty significant hepatic encephalopathy can have similar ammonia to patients who have very minimal encephalopathy. So I'll often use ammonia as supportive information when a patient is presenting with altered mental status, but I don't rely solely on ammonia to make the diagnosis. The other time I often see it used is patients who are being treated for encephalopathy, whose symptoms may otherwise be pretty well controlled, and they're getting ammonias checked routinely to help guide therapy. And there's really not a great role for that. We really tailor the therapy to the patient's symptoms as opposed to the lab value. So ammonia can be helpful. It's an important tool in our toolkit for diagnosis, but really when it comes down to the bottom line, the diagnosis is clinical. So when I'm assessing a patient with altered mental status and cirrhosis, I'm kind of doing three things at once. First, I'm ruling out any other causes. So particularly patients who have potentially, for instance, a focal neurologic deficit, making sure they don't have a stroke. You don't want to miss that, or some other cause of altered mental status. You also want to look for any precipitating factors that may have caused the patient to get more confused, and you want to identify those quickly and treat them. I'll talk about those a little bit more in a second. And while I'm doing that, I'm often starting empiric treatment with lactulose. So here are the most common precipitants of overt hepatic encephalopathy. Number one on the list is always infection. Whenever there's a patient with cirrhosis, they're coming in with encephalopathy, I'm always, of course, ruling out SBP, getting a paracentesis, as I mentioned earlier. That's a critical piece. But I'll typically also get blood cultures, urine, chest x-ray, and of course, assessing for any other symptoms, cellulitis, or any other infections that may be triggering the episode. The next most common four here are kind of all lumped together: electrolyte imbalance, renal failure, volume depletion. Often these are due to diuretic usage in the setting of ascites. It's not uncommon for patients to develop renal insufficiency on a stable dose of diuretics or to develop electrolyte issues. So these, as I mentioned earlier, also frequently a reason that patients become refractory, have ascites that's refractory to diuretics, because they just don't tolerate the diuretics that you need to be able to get the ascites under control. It can trigger HE, essentially, is what happens. Lactulose, again, is the mainstay of therapy for hepatic encephalopathy. It has been for a long time, and it continues to be so. It is a disaccharide that's not absorbed within the colon. Bacteria metabolize it to short-chain fatty acids, so you end up with an acidic milieu within the gut lumen. And that acidic milieu facilitates trapping of ammonia as ammonium, where you excrete it in the stool. And by doing so, you prevent ammonia from diffusing into the bloodstream, crossing the blood-brain barrier, and causing encephalopathy. Lactulose is very effective. Typically, we dose it on the basis of patients' bowel movements. So I'll usually recommend patients adjust their own dose of lactulose, or have their family member help them adjust the dose of lactulose so that they're having 2 to 3 soft bowel movements per day. Again, I don't necessarily target to any target ammonia goal or anything like that. It's more based on number of bowel movements and symptoms. Despite that, lactulose can be hard to tolerate. A lot of my patients don't like the taste of it. It can cause a lot of gas and bloating. And it's not frequently used as a laxative outside of liver disease for that reason. And so there are some data to suggest that other laxatives can be helpful as well. So for my patients who don't tolerate lactulose very well, I'll often ask them to potentially substitute a dose or two of lactulose with Miralax instead. And here's data from a pilot study where they actually compared the two, Miralax and lactulose. They found that there wasn't a significant difference in treatment of acute encephalopathy, whether you used Miralax or lactulose. And actually, there was even a trend toward quicker improvement of encephalopathy in those who received Miralax. So I don't necessarily, on the basis of this, I don't necessarily abandon lactulose. I still encourage patients to take some lactulose, but I may substitute, as I said, substitute some of those doses of lactulose with Miralax instead. These data also suggest that maybe the benefit of lactulose has been more the laxative effect anyway, and maybe it's less that gut acidification and more the laxative effect. But for whatever the reason, it seems to be effective. The other mainstay of therapy for encephalopathy is rifaximin. We've been using it now for over a decade in HE. It's highly effective at preventing breakthrough episodes of encephalopathy. It's highly effective at reducing rehospitalization for encephalopathy as well. And it also improves quality of life significantly across all sort of these domains: fatigue, symptoms, emotional function. So we use a lot of rifaximin. The main barrier to rifaximin use is just its cost, depending on the patient's insurance. Lastly, I just want to touch on protein restriction a little bit. I actually saw a patient just yesterday whose doctor had recommended that they restrict the protein in their diet because of their encephalopathy. The idea, this is kind of more historical, the idea with protein restriction is that by reducing the amount of nitrogen in the diet, you could reduce ammoniogenesis in the gut and potentially reduce ammonia levels. But clinically, it turns out not to be very beneficial. On the left here, you can see a figure where they compared patients on a low protein diet versus a normal protein diet. Really, on average, it didn't improve encephalopathy any quicker by using the low protein diet. And the big concern, as I'm showing here on the right, is that in patients who are on a low protein diet, they actually have greater breakdown of protein and they have greater protein turnover. And that's a big concern in this group of patients because patients are often already malnourished. You're often already trying to get muscle, you're dealing with muscle wasting and sarcopenia, and those independently are predictors of poor outcomes. So protein restrictions really fallen out of favor. And mostly in general, we don't recommend restricting protein for encephalopathy. So those are the ascites, HE. Now I lastly want to talk about variceal bleeding, the third sort of, the third kind of main complication defining decompensated cirrhosis. Varices form, again, because of portal hypertension. And they form in particular when the gradient across the liver, so that's the difference between the portal pressure and the hepatic pressure or pressure within the IVC, when that pressure exceeds 12 millimeters of mercury, that's really when patients are at greatest risk for development of varices and variceal bleeding. And about half of patients, when you diagnose cirrhosis, have underlying varices. And there is a pretty significant risk of bleeding at that point. And it varies quite a bit on the basis of how large the varices are, as well as the severity of liver disease. So patients with Child-Pugh C cirrhosis have an extraordinarily greater than 50% risk of variceal bleeding within 1 year, much less so for well-compensated Child-Pugh A cirrhosis. But you can see even in this group of well-compensated Child-Pugh A cirrhosis, if they have large varices, they have a greater than 20% risk of bleeding at 1 year. So the risk is significant across these stages. And for that reason, we recommend screening for varices in almost all patients after they've had a diagnosis of cirrhosis. And you can see a couple of endoscopic pictures here on the left. You can see some small linear varices in this figure on the left. And then on the right, much larger varices. This little white area is a fibrin plug. So that varix is at high risk of bleeding and would likely need prophylaxis. And then based on again, because of what we know about the underlying, the risk of bleeding related to underlying liver disease and the size of varices, you can determine when they would need a follow-up endoscopy, whether that's 2 to 3 years in a patient with compensated cirrhosis and no varices, But once they become decompensated and they're at much higher risk of having variceal bleeding, we recommend repeating it annually. So how do we prevent variceal bleeding? There's two main preventive regimens. First is using pharmacotherapy with beta blockers is the mainstay. Beta blockers function by, again, reducing splanchnic vasodilation and therefore reducing portal hypertension. They also have a role in decreasing cardiac output, thereby also reducing portal hypertension. And beta blockers are highly, highly effective. Here's results of a meta-analysis here on the right showing reduction in bleeding by about a half, as well as significant reduction in mortality from bleeding.
We got 4 minutes to wrap up, Dr. Orman.
Sure, I'm almost done here, sure. Important just to note, beta blockers, you should be looking at non-selective beta blockers. You don't want to use metoprolol or atenolol. They don't have that effect on beta-2 receptors that are responsible for splanchnic vasodilatation. So we use mostly propranolol, nadolol, and titrate to the heart rate, or carvedilol. Alternatively to beta blockers, you can do prophylactic banding. Again, that is associated with significant reductions in multiple studies of first episode of variceal bleeding, as well as mortality. Comparing the two, really it's sort of dealer's choice, and it depends on individual factors. And this is really a discussion to have with patients, because there's no overall mortality benefit when you compare beta blockers to banding. Here are some of the side effects of either choice. With beta blockers, of course, you can get hypotension, bronchoconstriction, whereas with banding, you can develop post-banding ulcers and bleeding or strictures. In the setting of acute bleeding, always thinking first airway, breathing, circulation. Want to make sure you're maintaining a good airway, reducing the risk of aspiration, having good circulation, good IV access. You want to focus on a goal hemoglobin of 7. That's a restrictive strategy, and that's been shown to be superior to a more liberal strategy of focusing on a higher goal hemoglobin. That's probably related to reducing overtransfusion, which can actually worsen portal hypertension. And then importantly, medications for variceal bleeding. I mentioned earlier antibiotics, but somatostatin analogs like octreotide are also effective at reducing splanchnic vasodilatation, and multiple studies showing that they're effective in helping with hemostasis, as well as a trend toward improving mortality. So after you've gotten antibiotic treatment, vasoactive therapy on, you want to make sure you get your gastroenterologist in quickly. They need quick therapeutic or diagnostic, as well as potentially therapeutic endoscopy within 12 hours, ideally, to get hemostasis. And then in those courses, in those rare cases where you have refractory bleeding, TIPS is really your option for more definitive management of portal hypertension. And everybody's familiar with Minnesota tubes or Sengstake and Blakemore tubes. Those are really a temporizing measure to get somebody to more definitive therapy. And then lastly, just to wrap up, after a patient's had a bleeding episode, I mentioned earlier, preventing bleeding using either banding or beta blocker. Well, in the setting of having had a prior bleed, actually the combination is better. Here's several studies showing that banding plus a beta blocker in combination is better than either one alone. And so that's the standard after a patient's survived an episode of variceal bleeding. So these are just kind of the brief take-home points. Ascites, just mainly think about, remember paracentesis early and often. Remember to counsel patients against using NSAIDs. For hepatic encephalopathy, remember it's a clinical diagnosis. Don't worry, don't fixate too much on ammonia levels. And importantly, look for those precipitants. Don't forget potential for underlying infection that caused someone's HE. And then in just for variceal bleeding, just remember when a patient presents with bleeding, those prophylactic antibiotics are important. And then you can use either beta blockers or banding, depending on patient and provider preferences, both before an episode of bleeding and then of course after, using both in combination. Thank you so much. Thanks for your time this morning.
Thank you very much, Dr. Orman, for an outstanding and comprehensive update on cirrhosis. We appreciate it very much. Now, we have got about 15 minutes for the question and answer session. So Dr. Janalagadda, will you be kind enough to moderate the session?
Absolutely. Thank you again for excellent talk, Dr. Orman and Dr. Chalsani. I think fat in the liver brought a lot of attention, Naga. I think you have a lot of questions in the chat box, and I'll try to go quickly. The first question is, how to differentiate fatty liver from the NASH?
Thank you. Once again, I enjoyed the talks by Eric Orban and Roger Reddy. Really brilliantly done, Dr. Ray Murray and Dr. Janalgada. So the thing from Dr. G. Reddy, I see this question in the chat box. The best way to do is a liver biopsy, but obviously can't do it bedside. Look at AST, ALT, platelet count, calculate the Fib score if it is high, and also if patients have metabolic syndrome, that tells you that the patients are at a high risk for NASH. That's probably what I would do without a fibroscan. If you have fibroscan, just look for a liver stiffness about 9, 10, then you're dealing with the NASH population.
Naga, one more question. What, apart from the liver biopsy, what is a non-invasive tool you use in your practice? Like, for example, keratin 18, like that.
Sure, we've done a lot of work both with keratin 18 as well as ELF. The keratin 18 fragments can identify patients who are at a high risk for NASH, but it is not available. We have it in our lab. And there is a test called ELF, which stands for Enhanced Liver Fibrosis. Siemens makes it. It is really a darn good test for identifying fibrosis. Once again, it's not commercially available. FDA did not approve it. Hopefully it'll get approved. But those are two blood-based tests that you can, but currently not able to.
Yeah. The Live 52 available in India is like Ayurvedic medicine. Does it work for the fatty liver?
I've seen just sort of reports, if you just sort of type Live 52 and fatty liver, you get a lot of hits. But what struck me is they're not really rigorously done, even a randomized controlled trial. That doesn't mean it doesn't help. I think anecdotally we have seen that to be helpful. I just can't speak to its efficacy in the absence of trials.
Okay. Thank you. That question to Dr. Orman, the patient with cirrhotic and especially encephalopathy, if he doesn't tolerate lactulose and cannot afford digoxin, what you do?
So again, we'll often try to substitute Miralax in some of these cases as well. And then if they can't get rifaximin, that becomes a big challenge. You can use other antibiotics. Neomycin's been used in the past. We'll use Flagyl on occasion. The concern with some of these is the long-term side effects. With Flagyl causing neuropathy, neomycin, there are concerns regarding renal insufficiency, but it can be a real challenge for these patients.
So you can try Miralax.
May I say a thing about this, the population you just mentioned, Doctor? Jazz Bajaz from VCU has been studying FMT, fecal microbial transplant, in this population for HE, and I think he had some early success. Dr. Orman and I are part of a trial that we are submitting to the NIH to study FMT in cirrhotic population for hepatic encephalopathy. So I think there may be some excitement on that front. And by the way, FMT doesn't mean that you're going to give these stool via colonoscopy. These are capsules. There are a couple of companies that have these microbial capsules that just seems to be pretty exciting development.
Thank you. Another question is vitamin E recommended for patients with fatty liver or non-alcohol fat? I think the answer is yes. I think you can use for both, I guess. They're pretty much the same. Fatty liver, non-alcohol fat, both are same.
I think the question is, which subpopulation you want to give your vitamin E? What I can tell you is just all comers NAFLD, it's unnecessary. As I said, 80%, there is no risk of progression. And then you talk about risk of prostate cancer, very slight. And then there may be some lack of efficacy with statins. So I restrict vitamin E to NASH patients. It is up to you whether you want to do a biopsy or you just want to use your Gestalt or just FibroScan. That's you as a clinician, that's your prerogative. But I would restrict it to just NASH or at-risk NASH population.
Yeah. Coming to the liver biopsy again, the patient with NASH, how often do the liver biopsy? And if you do a liver biopsy, does it alter your ultimate management?
No, really good question. This is a question that I've been as since I started in the field 20 years ago. So let me tell you what I do what we do in our practice. We do, after evaluation, we do a fibroscan. If the fibroscan tells us, hey, here is a patient who is at risk with a high liver stiffness, that's the patient we subject him to a liver biopsy. For one, to confirm. Number two, we have a number of clinical trials. And then also, I think this is, you have a baseline. You know, once you have NASH, the risk of cirrhosis over the course of next 10 years is 20%. And I think patients would want to know whether they just have this relatively trivial NAFLD or more sort of a virulent phenotype NASH. So I'm a proponent of biopsy, but in selected patients. And would it change the management? I would think so, just because you can give things, you can get them in clinical trials, and then there is the patient motivation I wouldn't underestimate. And then colleagues from India really push back, and that's fair. You know, liver biopsy in India is hard to do. It's not an easy thing. I mean, I think we all do what we can for our population.
The next question is hepatocellular carcinoma can happen with patients with NASH. I mean, so how often screen these patients?
You know, a really good question. Unlike hepatitis B, where HCC can occur, liver cancer can occur in patients without cirrhosis. NASH, to most part, it only happens in patients with cirrhosis. Today's recommendations are not to screen NAFLD, not to screen NASH, only screen those with cirrhosis. And the AASLD guidelines recommend every 6 months ultrasound, but this is obese population. So we at IU been doing CT scans every 9 to 12 months in nice dual or triple phase with IV contrast, with and without contrast. And that really has a phenomenal efficacy. When it comes to HCC, let me make one more point. I meant to say in my talk, and I've forgotten, that men are significantly higher risk for HCC, regardless of etiology, than women. We're talking 90 to 10%. So for example, you have a NASH cirrhotic woman with NASH cirrhosis, I think you can take some liberties. Their risk of cancer is much lower than a male with NASH, any type of cirrhosis for that matter.
Okay, great, thank you. There's one case here. The 30-year-old refused to help for alcoholism, now quit for 1 year with the first son, but how do you help him?
You know, I think I saw that in the chat room as well. Really good question. We see that quite a bit. First and foremost thing is to help however we can for him to stay sober. That alone will buy them decades of life. But if they're already, I would evaluate the extent of liver damage that they have. Many times, especially at that age group, even if they had alcoholic hepatitis, there's a good chance they will recover without significant fibrosis. If that happens, that's a lucky chap. You know, they're not going to get into variceal bleeding, varices, and cancer, etc. But if they unfortunately have cancer, screen for HCC and varices, as Dr. Orman has suggested, has spoken. And if you go to places like China, this population, they use SAMe, adenosylmethionine. We are doing a trial with SAMe at IU and University, Southern California. That's another over-the-counter drug you might consider, but fundamentally, though, they need to stay away. Their ecosystem needs to change, their friends, and why they resort to alcohol as response to stress and anxiety. I think those sorts of things need to be addressed.
Okay. Dr. Orman, a question regarding the coagulopathy. The patient with ascites with the coagulopathy, can you start antibiotics 7 days without parasynthesis because of the high INR? Because a lot of, he said in the parasynthesis has been refused by the hepatologist or radiologist. You know?
Yeah, that's a common problem, and we sometimes run into that as well at our center. Even though we're very experienced, we're relying more and more on technology called thromboelastography, which is a different way of measuring coagulation in end-stage liver disease. And it's essentially a whole blood measure of coagulation that's independent of some of the confounding factors that we find in the standard INR and platelet count. And it turns out when you do these TEG tests, you find that actually patients with cirrhosis have quite a bit of preserved coagulation function, and they often don't need any blood products, for instance, and that these procedures can be done safely. But I absolutely, particularly when you're working with these sick patients and it's a multidisciplinary setting, you're working with others and having to address their comfort level as well. So on occasion, we have had where we were unable to get a paracentesis because of somebody's reluctance, even after we discussed the data. And in those cases, we've certainly treated empirically for SBP, but we really prefer not to when we can avoid it.
Another question to you, do you have preference between 25% albumin versus 5% in treating a patient with ascites?
Sure. Yeah, great question, because we use both, and it really depends on the situation, and I really focus on their volume status. So for patients who are many of our patients are already grossly volume overload and have significant edema, those are the ones we'll go with the 25% just to avoid giving more volume, as opposed to patients who are profoundly hypovolemic. Then I might lean toward the 5% albumin. So it's really an individual decision based on a patient's volume status.
Thank you. Now I got one more question to you. The ultrasound shows fatty liver, and how accurate, if you do a biopsy, they are fatty liver?
Generally speaking, if ultrasound says highly echogenic liver, they're looking at compared to kidney, compared to spleen. Generally, that's pretty darn good, But keep in mind, ultrasound picks up fat when it exceeds this threshold of 30%. So you're already seeing a fair bit of fat. So I would say it is less sensitive, more specific. So there are people with 15, 20% fat, you just miss an ultrasound, but that's okay. Clinically may not be relevant. But the important point though is of those who have hepatic steatosis by ultrasound, how many have meaningful subphenotypes like NASH? I would say 15%. How many would have NASH with fibrosis? 5 to 10%. How many have NASH with cirrhosis? 1 to 2%.
Naga, one question. There's a Mediterranean diet. Is it something like to comment on that, please?
Yeah, really, really good question, Sudhakar. I recommend Mediterranean diet, but importantly, I tell patients a couple things. I think one is restrict carbohydrates. I think this actually all of us with our Indian genetic architecture should do. One is I think we should restrict carbohydrate usage, especially refined sugars. It's just awful. Number one. Number two, protein intake. I think I can tell you just the population Dr. Orman described, or the population that I study, just have tremendous sarcopenia. And then I think high protein intake, the most you can. I mean, it's just hard to get in enough protein, but biologically valuable protein, in egg whites, wherever you can get protein is really critical. So I've been focusing on those. And then also I'd like to sort of an observation we made is that this triad of post-menopausal women with poorly controlled diabetes, with advanced liver disease, their muscle melts. They can't even walk upstairs because they have such weakness of quadriceps muscle. And physical therapy and high protein, all that you can do. But I think muscle wasting, just the nutrition is really critical.
Okay. Thank you. Comment on this, pharmacological treatment with aldafermin. Aldafermin is new drug coming in the market, I think.
Yeah, sure. Aldafermin, it's an NGM19 molecule. NGM is the name of the company. It is a very interesting engineered molecule, human FGF19. This is a fibroblast growth factor 19. We've studied FGF21. We have now gone into, at least in our pig models. And it seems to be really profound. At the liver meeting, Sudhakar, that we just had this past fall, Steve Harrison presented the data on FGF19. Just in 16 weeks, there was profound reduction in fibrosis. One downside of FGF19 is 90% will have increase in LDL. So the particular study, what they've done is they've done LDL at 2 weeks, and if the LDL has gone up by 10 milligrams per deciliter, they got put on 20 milligrams of atorvastatin. So I would argue it's not the treatment with NGM 282 aldafermin. It is actually aldafermin plus atorvastatin therapy, because everybody eventually got put on it. But there's about to start a phase 3 trial. We may participate. That's an exciting molecule, but mind you have to take it by injection.
It's an interesting question. Is olive oil helps for alcoholic cirrhosis prevention?
You know, there are data to suggest that saturated fat is better than unsaturated fat in alcoholic liver disease, at least in animal models. At least in animal models for rats and mice, if you're feeding alcohol, then you play around with various degrees of saturated and unsaturated fat. Strangely enough, saturated seems to be better. Olive oil seems to have both saturated as well as polyunsaturated fatty acids. So arguably, I'm not familiar of any data. And yeah, you know, if somebody just likes to enjoy their 2 drinks, and if you want to minimize, I suggest giving you a holiday. You know, there are people that just do dry Januaries and dry February. They drink 9-10 months. That's a reasonable strategy if one of you are just thinking about your own risk.
A couple of questions to Dr. Orman. What scenario do you use? Do you order ammonia levels?
So, a great question. I think, like I mentioned, it's most helpful in the setting of acute worsening mental status in a patient with known liver disease. And I'm trying to use it as supporting information, either that this is encephalopathy or trying to sort out whether there might be something else going on. I put a little bit of stock in it, but I don't put too much stock in the ammonia. It's really just a supporting piece of information. And if the ammonia level, for instance, is low or normal, then my suspicion's got to be a lot higher that I'm missing something else.
Okay. One more question to you. When do you intubate the patient for endoscopic intervention in cirrhotic patients?
Again, it depends on the scenario. Great question. For someone who is coming in for just a screening endoscopy, or someone who's otherwise stable as an outpatient coming in for routine banding even, we tend not to intubate. However, if someone's got acute GI bleeding in particular, especially if they have hematemesis or have active upper GI bleeding, that's the scenario you definitely want to be intubating patients.
Yeah. Thank you. Dr. Murthy, I have one question, or we can wrap up.
No, please go ahead.
Yeah. Naga, this question for you. As a community hepatologist and gastroenterologist, you know, we often face this vitamin E issue. When you tell the male patient that, you know, you have a liver problem, fatty liver, and we have used vitamin E, and we have to tell them that is a low risk of prostate cancer and also cardiovascular risk for them, okay? Immediately they will say no. What to do next? How to convince them, or if you convince them, you know, do you need to document in a chart that, you know, risk and benefit has been explained, something like that?
Yeah, really good. That's where I think you want to select patients. If you have somebody has stage 3 fibrosis or cirrhosis, I think you can just tell them what you're talking about, the risk of prostate cancer, and extremely small. We are talking in a high-risk population, 1 in 10,000 was in that particular trial. And then cardiovascular risk, I think, is pretty nebulous. I think what you want to say, at least what I tell is, you have cirrhosis or risk of cirrhosis. This is real to you. This risk is real to you. In your lifetime, there's a chance you're going to die from liver disease as opposed to others are hypothetical. And just leave it up to them. And I've not had a patient who turned me down. But by the time they come to me, they're quite motivated. That could be an issue. But I think you would document. And not only that, though, at annual visits, I've been documenting. You know, each time I sort of bring up, hey, there is this minuscule risk. And I say with confidence, I don't think it's for real. You know, that the risk from vitamin E, but the benefits are real, though. I think that's really how I've been framing my sort of discussions with patients, and I've had good luck with it.
Okay. Thank you very much thank you again for an excellent presentation, Dr. Orman and Dr. Naga and Dr. Reddy, for a valuable time and presentation on the Saturday morning. And we really enjoyed. And thank you to our members to join us today. Dr. Murthy, it's time for a presentation of the plot.
Please.
Vijaya, Dr. Sajani Shah is on the line, please. Sajani?
Dr. Shah, if you are there, please unmute. Thank you.
I'll go and do it. Thank you again. The American Association of Indian Origin recognized Naga Chalasani MD for his outstanding contribution to hepatology and welcome him as a member of AAPI Distinguished Speakers Club. Sudhakar Janalagada, President, Vemuri S. Murthy, Chairman, AAPI Webinar CMA Committee, January 23rd, 2020. Thank you very much, Naga. Thank you very much.
Thank you, Sudhakar. It's truly
Next
been a
slide.
privilege. And really, I cherish this. This is special just because I'm speaking to my tribe. This is, I'm like rest of you. So great honor on this Saturday morning.
Thank you very much. Yeah. Next one, please. American Association of Physicians of Indian Origin recognized Eric Oman, MD, for his outstanding contribution to hepatology and welcomes him as a member of AAPI Distinguished Speakers Club. Sudhakar Janalagada, MD, AAPI President 2021, and Vemuri S. Murthy, MD, Chairman, AAPI Webinar CMA Committee, January 23rd, 2021. Thank you, sir. Thank you very much for joining today. Indeed, thank you very much.
We apologize
very
for
much.
the typo.
Much appreciated.
We apologize for the
Typo. We'll change it and we'll mail these plots for you guys. Thank you very much.
Thank you so much, and thanks everybody. And this concludes the program, and have a wonderful weekend.